السلام عليكم.
وعليكم السلام.
وعليكم السلام
وعليكم
ورحمة
السلام
الله.
sir.
How are you guys?
Alhamdulillah, fine sir. How are you?
Yes, fine. Okay. Today, inshallah, we'll practice some stations for newborn resuscitation and APLS resuscitation. Just briefly, newborn, it means within 24 hours. Maybe the baby born now, 0 minutes, maybe 24 hours. Okay. APLS, it means more than 24 hours, up to 18 years. So regarding the cardiac arrest for newborn, if the heart rate less than 60 or no breathing, you can consider cardiac arrest. Okay. If the baby more than 24 hours, I want to say cardiac arrest if the baby has no breathing or irregular breathing or no central pulse. What if the baby more than 24 hours and has heart rate more than, less than 60? You consider what baby?
براديكاردي
Bradycardia.
براديكاردي
Excellent. Okay, so not cardiac arrest. Easy. Okay. So if the patient baby more than 24 hours until 18 years, he has bradycardia. What is the first action?
optimize oxygenation.
Optimize oxygenation.
Oxygenation. Okay, so in circulation, you will do non-rebreather mask, 15 liters, or back valve mask, 15 liters. It depends on the respiratory rate.
وش
Anyway, we'll go in details now. So you have two stations in the exam, Resus. Inshallah, next decision will be ATLS, and then the following session will be practical skills and teaching, then two sessions for examination, then two sessions for communication skills and mock exams. Just to remind you, you have 5 domains to get 10 out of 10. Accuracy means checklist. Skillfulness should be fluent. And efficiency structure organized, just to follow the arrangement of checklist. Supportiveness in history or examination, it means good eye contact, rapport empathy, sympathy, check comfortability, address symptoms, including pain or any other symptom. Then information or questions in pieces, and pause between pieces, check understand. Supportiveness in resuscitation, it means you should raise your voice, be fast, and your eyes always on the monitor, your eyes on the actors, on the patient, like that, okay? In real practice, of course, your eyes on the nurses, on the patient, on the monitor. You can understand the status of the patient from the face, okay? So safety, correct information, like differential diagnosis or decision. In resuscitation, safety here, it means full assessment, correct full findings, correct full call, correct full interviews. Okay. If you follow this, for sure, you will be safe doctor. Okay. So we finished the last session, ALS. Today we will practice newborn resuscitation. Then stridor. Stridor here, which system?
respiratory airway
Airway.
Airway, not respiratory. Okay. So A, not breathing.
Mm.
Okay. Regarding stridor, maybe the patient has anaphylaxis. They will mention clearly in the scenario. Okay. the patient has, for example, rashes or stridor or anything after eating or after medication, you will understand it's anaphylaxis. Maybe they will mention the patient has foreign body in his mouth, so it means shocking. Clear, guys?
Yes.
They will not mention stridor, or even they will mention stridor, no problem, but you will understand shocking. So foreign body term already clear in the scenario. So if they did not mention foreign body in the scenario, don't think about foreign body. I'm talking about for the purpose of the exam. In real practice, you should consider everything, but in the exam, no need to consider everything. Clear, guys, this point?
Yes.
They will focus on something, okay? So if they give you foreign body, they will mention that clearly in the scenario. So when you ask the examiner, you will ask him about foreign body by name, but only in case the examiner mentioned foreign body. Otherwise, no need. In bronchiolitis, which term, which system?
B. Breathing.
Breathing, okay. Asthma,
Breathing.
breathing, okay. We finished already shocking on foreign body, so airway also. Diarrhea, vomiting, which system?
Circulatory.
Circulation.
Circulate.
Seizures,
D. Disability.
disability. Methadone toxicity,
D. Disability.
Disability.
disability also. So opiate toxicity. Methadone means opiate toxicity. Hypothermia,
Exposure.
exposure. If the patient is alive, you will catch hypothermia in exposure. If the patient in cardiac arrest, you want to catch hypothermia for H40s.
Or H40s.
Yes. Yes.
For
Yes.
H40.
Right.
Anaphylaxis,
Airway.
airway. Airway only?
Circulatory.
Airway breathing circulation.
Circulation all.
It could be airway, not all. It could be airway or breathing or circulation or exposure, like rashes. Okay. It could be disability also. Yes, if the patient is unconscious or anything like that. Okay. So we will jump to the general approach checklist, same as adult. Introduction, then hand over from ambulance crew or the relatives, maybe mother, maybe carer, maybe guardian, maybe father. ABCDE, full assessment, full findings, full call, full intervention in airway, full assessment, full finding, full call, full intervention in each system. Then after you finish the mannequin, hand over to relevant specialist. So before the mannequin, after the mannequin. Before the mannequin, we are calling
Hand over from ambulance.
hand over from. After the mannequin,
Hand
Hand
over.
over to.
hand over to. Easy? Okay.
Yes.
So hand over from mannequin, hand over to, then mannequin again. Okay. So your reassess ABCD. Reassessment will be brief. Already you finished first assessment. In real practice should be full each time. But for the purpose of the exam to save time, brief. Clear, guys? Okay.
Yes.
So what if you finished A, full assessment, B, full assessment, C, full assessment, and the patient has cardiac arrest in C, okay? Then you did resuscitation, the patient has ROSC. After ROSC, you will start with
ABCD.
A. So the patient has cardiac arrest in C or in D, and then you have ROSC, you will start from
A.
A, B, C, D, E, okay? A, B, C, D, E, it will be full, all, or brief.
If I
Full.
check before, it will be brief.
Anything assessed before cardiac arrest full will be brief after cardiac arrest. Anything assessed, not assessed before cardiac arrest, it will be full after ROSC. Easy?
Yes.
For example, you finished full A, full B, full C. Then after ROSC, brief A, brief B, brief C, then full D, full E. Easy?
Yes.
To save time. Again, in real practice, it will be full every time to be safe. Okay?
إن شاء الله.
Okay. So in each system, full assessment, full finding, full call, full intervention. For example, airway, full assessment, full finding, full call, full intervention. In breathing, full assessment, full finding, full call, full intervention. In circulation, full assessment, full finding, full call, full intervention. So each system, you should follow that. Okay. What if the patient has normal airway? No need to mention finding, no need to mention call, no need to already normal. For example, breathing. You find the breathing normal. You finish the full assessment, you find the breathing normal. Do you need to verbalize finding? No finding. Do you need to call anyone? No. Do you need to do any intervention? No. When to verbalize the finding? If the patient has problem, for example, breathing 8 points, you find the 3 points abnormal, mention them. If you have suspected diagnosis, mention that also. Then call. In adult, we will say ICU team. In adult, ICU team, plus the relevant specialty. In pediatric, which team?
Pediatric ICU team.
Pediatric.
Pediatric ICU team plus the relevant specialty. Okay. So, for example, the patient has methadone toxicity. So, call pediatric ICU team, contact the toxicity.org, like that. Okay. Regarding full assessment, it will be the same as adults. So, but instead of saying, is the patient conscious, you will ask, what is AVPO score? Clear, guys?
Okay, clear.
Okay, so what is AVPO score? Maybe alert, A, maybe V, verbal, responding to verbal. So, for example, the patient is sleeping. Once you are calling baby, baby, the patient is opening eyes, so responding to verbal. Or P, responding to pain. The patient is unconscious. You are calling baby, baby, he's not opening eyes. But when you stimulate, like pinching or anything painful, so the patient is opening eyes. You unresponsive. Even with the stimulation? Yes, even with painful stimulation. So regarding AFBO score, in adult, how many signs of instability?
4.
4. Shock, syncope, myocardial ischemia, signs of heart failure, or ROSC. Clear?
Yes.
So these are the new guidelines. You have 5 signs of instability. Again, shock, syncope, myocardial ischemia, and ROSC. Okay,
Cross.
heart failure. Okay. So in pediatric, you have 3 signs of instability. Number 1, not A. What does it mean, not A? VBU. Easy?
EU. Yes.
So if the patient A, alert, or crying it means alert. So if the patient alert, it means stable. Any baby coming to ER crying, you should be happy. The patient is not crying or not looking or not opening eyes. It means verbal or pain or unresponsive. It means unstable. Clear, guys?
Yes.
So number 1, not A, signs of instability. Okay. Number 2, CRT more than 2. CRT more than 2. Number 3, systolic blood pressure less than normal. So how many now?
3.
3. Number 1,
ABB
Not A.
not A.
so AFB score not A. Okay. Number 2, CRT. Number 3,
30.
systolic blood pressure.
Blood pressure.
Yes. So AFB score disability. And regarding the CRT blood pressure circulation, right?
Yes.
So signs of instability in pediatric, circulation, and disability. Done. Okay. So number 1 in airway, what is AFB score? Then is the airway patent? If patent, apply high flow oxygen. If not patent, verbalize clear airway, oropharyngeal, nasopharyngeal, apply high flow oxygen. Okay. Um, Doctor asked yesterday in the group, do we need to mention apply high flow oxygen in breathing? When I say to the nurse, apply high flow oxygen, she will go to the equipment and attach the oxygen and turn on the oxygen. Already I finished the breathing. Clear, guys, this point?
Yes.
So no need to wait for assessment of breathing, then ask her to apply high flow oxygen. She will take further time. No, any patient, life-threatening, apply high flow oxygen. The nurse is preparing. I already finished airway and breathing. Clear?
Yes.
Okay, so once you finish number 8, the nurse already prepared everything, and I have already idea about SpO2 before applying high flow oxygen. I wish it's clear. So if I give you something, any approach, just follow the approach blindly. Okay? Breathing, same. You will ask, same as adults. Expose the chest, connect all monitors. What about SpO2? Are art, radiating veins, inspection, palpation, percussion, auscultation of lungs and heart. You can ask one by one. You can ask two by two. You can ask three by three. You can ask all together. For example, I'm asking the nurse or the examiner. Expose the chest, connect all monitors. What about SpO2? Are art, radiating veins, inspection, palpation, percussion, auscultation. And the examiner can give me all together. I will save time, no problem. Clear, guys, this point?
Yes.
Okay. Circulation, I can ask about the 4 points together. So instead of wasting 2 minutes, I can save time. Okay. So what about blood pressure, CRT, peripheral pulses, heart rate? Done. Disability. What about AFB score? Any signs of lateralization? What about pupil? Equireactive? What about blood sugar? Also, the examiner can give me the 4 points altogether. No problem. Exposure. Any other abnormality? What about temperature? So you can finish full assessment quickly. So full assessment. Once you find any abnormality, mention the abnormalities, mention the diagnosis, then call, then do intervention. Regarding the general approach, guys, you can zoom from your monitor. Okay, if you have phone, you can zoom. Did you try now?
Yes. I save it in the laptop already. Yes.
You can zoom. Instead of zooming from my side, you can zoom from your side. Okay, so you have bradycardia and you have tachycardia. So if the patient has signs of instability, what does it mean, signs of instability?
The 3 point.
3 point AVO score, blood pressure, and CRT.
AVO score not alerted. Don't say AVO
Yes.
score only.
Yes. Yes.
Not enough.
Alert.
You should say
Not alert.
not alert. Number 2, CRT more than 2 seconds. Systolic blood pressure less than normal. So systolic blood pressure, what does it mean? 1 month, 1 year, 5 years, 10 years. So 1 year, the normal blood pressure, how much?
70.
70. Okay.
Near 70. Oh, yes.
Yes. So 1 year, it means 70. Okay. 5 years increase 5. So 70 plus 5.
75.
10 years increase 10. So 70 plus 10.
80.
80. Done. So 1 year, 70. If you remember 1 year, 70, easy for you. Easy? Okay.
Yes.
So the patient has signs of instability and the bradycardia. What is the first action?
Optimize oxygen.
Optimize.
Oxygen. Okay. So bradycardia, it means which system?
Circulation.
Circulation.
Circulation. Okay. Tachycardia, which system?
Circulation.
Say circulation. Okay. So when to discover bradycardia in circulation? You finish the airway, you finish the breathing, you go to circulation, you found the bradycardia. I want to say bradycardia. If less than 80 in first year, less than 60 above 1 year. Okay. Then give oxygen. Done. Don't do anything. Not like adult. In adult, we are giving atropine. No. In pediatric, no. Okay. So this guidelines 21. We will follow 21 or 25. Same. No change. Some people will say which one to follow. This 21 and this 25. Okay. So almost the same. So
Adenosine doses, doctor, I think it changes. Fixed.
yes, adenosine, I was advising people in all the recordings, this is the 21. I was advising people use 150 or 100. They followed my old recordings. They said you can follow any of them, flexible. Okay. The signs of instability of adult. Before I'm advising people in all the recordings, I mean all the recordings in 2018, maybe this recording for all the batches. I was advising people the patient has ROSC, it means unstable because just ROSC now, if the patient has syncope, you are giving shock, right?
Yes.
Patient alive, did not reach cardiac arrest. Patient alive. Once he got syncope and arrhythmia, you are giving shock. And then I told old batches, if the patient has ROSC, which is serious? Patient has ROSC or patient has syncope?
Rusk.
Has ROSC.
Has ROSC. I advise the people in all the batches, if the patient has ROSC and you found after ROSC, even he's conscious, he has arrhythmia, give shock. Clear? And they followed the old recordings, alhamdulillah. Anyway, so everything always flexible. Don't worry. For example, the dose is 100 and you mention 150 microgram. Don't worry. If the dose is 150 and you mention 100, don't worry. Okay. So the difference between all the guidelines and new guidelines, they choose any of them. Before they said up to 1 year, 150, 1 to 11 years, 100 microgram. I advised all the batches to use any of them, no problem. So they followed that. So the dose flexible, 0.1 up to 0.2, easy.
Yes.
It means 100 microgram up to 200 microgram. Anyway, it's not our issue now. So the new guidelines say, so here regarding bradycardia, the first action in circulation, oxygen, done. Ignore circulation, go to disability. In the second circulation, you find the patient still has bradycardia. What is the next action?
Atropine.
Oxygen. Why
Oxygen
atropine?
also.
Oxygen.
Yes.
Okay. So the patient has no response, give oxygen. And go for D. Then once you reassess the patient in circulation the third time, you find the patient has bradycardia. What is the next action?
Oxygen.
Oxygen. So each time you find the patient has bradycardia, what is the action?
Oxygen.
Oxygen. Don't do anything. Easy?
Yes.
Okay. How when to do chest compression? How when to do chest compression? In the second circulation, if the patient unconscious and the heart rate less than 60. Clear this point?
Yes.
Again, when to do chest compression, I said chest compression, not CPR. There is difference between chest compression and the CPR. Okay? Chest compression means heart massage only. Okay? 3 to 1 in neonate and 15 to 2 in above neonate. Easy? Okay,
Okay.
so chest compression only. If the patient unconscious, when the examiner says the patient is unconscious or unresponsive, and the heart rate less than 60. In first assessment or second assessment?
Second assessment.
Second assessment. It means if you find in first assessment the patient is unconscious, heart rate less than 60, what is the next action?
Oxygenation.
Oxygen.
Find
Oxygen. Oxygen. Don't do chest compression. But in second assessment, you find the patient is still unconscious and the heart rate less than 60, what is the next action?
Chest compression.
Chest
Chest
compression.
compression.
Excellent. Okay. So I will continue chest compression forever? No. I will give chest compression until the
Heart rate.
indication finish. Clear?
Yes.
Yes.
What is the indication to start chest compression? Unconscious plus heart rate less
Bradycardia.
than 60. It means when to stop the chest compression?
If he
Conscious or
retain
heart rate more than
consciousness.
60.
Any of them. So to start chest compression must be both of them. But to stop chest compression, one only enough. Easy?
Yes.
So if you are doing chest compression, 3 to 1, 1, 2, 3, one ventilation. 1, 2, 3, one ventilation. 1, 2, 3, one ventilation. Then the baby crying. What to do?
Stop.
Stop chest compression.
Stop chest compression. Easy?
Yes.
Yes.
Okay. Or the patient opening eyes. So stop chest compression. The patient is still unconscious. You are doing 1, 2, 3, one ventilation. 1, 2, 3, one ventilation. The patient is still unconscious, but you find the heart rate on the monitor 70. What to do?
Stop chest compression.
Easy?
Yes.
Okay. When to give atropine? If the patient has vagal stimulation. What does it mean? The patient came to the hospital normal. He has vomiting. Once you give him injection, antiemetic, the baby, afraid of injection, became
Yes.
bradycardiac. What is the next action?
Oxygen.
The patient has bradycardia after injection, antiemetic. What is the next action?
Oxygen.
Oxygen.
Oxygen. Excellent. Not atropine. Yes, not atropine. Any bradycardia in pediatric, oxygen. Easy?
Yes.
Okay. The second assessment, second circulation. The patient is still in bradycardiac. Then you can give atropine. Easy?
Yes.
So he went to give atropine in the second
Yes.
assessment if the patient has vagal stimulation. The examiner said, for example, another possibility, after intubation, you said, I will intubate the patient, for example, because of airway problem. Then, after intubation, became bradycardiac. What does it mean? Vagal
Vagal
stimulation. So, what is the next action?
oxygenation. Optimize the
Oxygenation. Already, when you intubate the patient, you are connecting to back valve mask. One ventilation every. Be active, guys. We will waste the time like
3
that.
seconds.
3.
You want
One.
the session to be 5 hours? One ventilation every
3
3
seconds.
3 seconds. In
3
adult,
seconds.
every 6 seconds. In pediatric, every 3 seconds. So you will optimize oxygenation. You intubated the patient, optimize oxygenation. You find the patient bradycardiac, don't do anything. Just ventilation. Continue ventilation. Don't do anything. Easy. But in
Yes.
second assessment, the patient already connected to intubation and back valve mask, but you find the patient is still bradycardiac, then you can give atropine. Easy.
Yes.
It will be in
Yes.
second assessment. Okay. He went to
No
give
need for chest compression, right?
sorry?
Immediately. No rule for chest compression. Immediately atropine medications, right?
No need for chest compression. The only indication of chest compression, unconscious and
Heart rate
heart rate
less
less
than
than
60.
60. If the patient you intubated, if the patient you intubated without medications, for example, the patient is unconscious and you did not give any medication, it means unconscious. If you find the heart rate less than 60, here you can do chest compression even is intubated. Clear?
Yes.
Yes.
But if the patient was conscious, but his airway compromised despite high flow oxygen and despite despite back valve mask, and you did rapid sequence induction, I will not consider unconscious. I will consider sedated, right?
Yes.
Okay. So it will be clear anyway. So when to give adrenaline? Adrenaline,
Third.
the patient here arrhythmia, the patient here alive. The patient here not responding to atropine. So the only case to give adrenaline, it will be one time. So atropine here one time, adrenaline one time, okay? Because it's not CPR. So you want to give adrenaline if the patient has vagal stimulation. The first circulation you give the baby high flow oxygen. The second circulation you give atropine. The third circulation the patient is still brady. What to give?
Epinephrine. Adrenaline.
Adrenaline. Easy?
Yes.
Okay. So
Important to know the dose يا دكتور هاني.
the dose here. We will not focus on the dose now. You have everyone has a screenshot, so you can focus on the dose. For example, atropine, this 2025, it will be 20 microgram. regarding adrenaline, 1 microgram per kilogram or 2 microgram per kilogram. Clear?
Okay. Yeah.
So he went to give atropine in the second assessment if the patient has vagal stimulation. He went to give adrenaline in the third assessment if the patient has vagal stimulation, not responding to what?
To atropine.
Oxygenation and atropine.
Okay. So the first circulation not responding to oxygen, second circulation not responding to atropine, third circulation not responding to adrenaline. If no vagal stimulation, X. What does it mean, X?
Don't give them.
No need.
Cancel. Cancel.
Yes.
Okay. So the patient has no vagal, no atropine, no adrenaline. Easy.
Yes.
No unconsciousness. Heart rate also not less than 60. Cancel what?
Chest compression.
Just the compression.
Chest compression.
I'm giving you treasures. Yes, the guidelines, I'm not the one putting, but I'm giving you treasure by clear explanation. Easy? Okay.
Yes.
So, what about tachycardia? We finished now bradycardia. Tachycardia same as adult. So, tachycardia easier than bradycardia. So, SVT, it means heart rate more than 220 in first year or more than 180 after 1 year. Why they mention that? Because maybe sinus tachycardia. So if less than 220, sinus tachycardia, don't do anything. If less than 180, sinus tachycardia, don't do anything. Okay? So if SVT or VT and unstable, means AVO score not earlier, it means CRT more than 2, it means systolic blood pressure less than normal. So in such a case, give synchronized cardioversion. Okay. If the patient unconscious, do you need to do anesthesia or sedation?
No.
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 Do you need to take consent? No.
No.
No consent in emergency, whatever adult or pediatric. Okay? Even the patient conscious, You want to give shock? Don't tell the patient, I will give shock. Clear, guys?
Yes.
Don't tell the patient, I will give you sedation and I will give you shock. No need. The patient emergency. He will say yes or no. Will it affect the decision?
No.
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 Okay. So SVT or VT, you will give synchronized this shock because alive. Arrhythmia means alive. So it will be the new guidelines. They said first this shock 1 joule, then you can increase to
2 joule, 4 joule.
4 joules maximum.
So the new guidelines they increased in APLS. Okay. So anyway, you can do 1 joule, 2 joules, 4 joules, like that. Okay. Regarding if the patient conscious, you need sedation. Which sedation in pediatric? Ketamine.
Ketamine.
You can give IM fast. You can give IV if IV access. If the patient has no IV access, okay, so intranasal or IM. Okay. If the patient is unconscious, no need for sedation. Okay. So conscious, it means A, alert. If V, no need. If P, no need. And if U, no need. Okay. Regarding cardiac arrest, the cardiac arrest, the previous guidelines 2021, they said 5 initial breaths, then ratio, cardiovascular chest ventilation ratio, chest ventilation ratio, 15 to 2. In new guidelines, they did not mention 5 initial breaths. Do you think they forgot that?
No.
No.
Maybe this possible. Why? Because in shocking new guidelines, they mention 5 initial breaths. In basic life support, they mention 5 initial breaths. So it could be. Okay. So for the purpose of the exam, give 5 initial breaths, then high quality CPR, no problem, don't worry. Okay. So
Okay.
here, new life support, their newborn. This is the old guidelines, and this is the new guidelines. The modification here in the oxygen saturation. Before, they said the accepted oxygen after 2 minutes, 65, 5 minutes, 85, 10 minutes, 90. So they change after 3 minutes, 70 to 75. This common question in the station, the examiner or the nurse can ask you how much oxygen saturation accepted after 3 minutes. Or they can ask the accepted preductal SpO2 at 3 minutes. Clear, guys? So 3 minutes,
Yes.
70 to 75, 5 minutes, 80 to 85, 10 minutes, 90 to 95. This is the only modification. Okay. So we will give idea before each station. Anyone will practice. We have now for practice Anwar, Ali, Omar, Kalyan, Basamat, Muzammil, Giovanna. If anyone interested to practice, raise your hand. We will give idea for everyone. Okay. So Anwar,
Burhani,
yes, please.
Yes.
I have a question before we start.
Mm.
They wrote in the algorithm, consider amiodarone before the third shock. I can give amiodarone before third shock in tachyarrhythmia, or
Yes,
like other
you
after
can
third
give
shock.
after the second or after the third. It's up to you.
Okay, thank you.
Welcome. Okay. So here, even in adrenaline, in OSCE, the American, I'm talking about cardiac arrest, not alive, not arrhythmia. Okay. So
Mm.
even adrenaline in cardiac arrest in American after second, in UK or British after
Third.
third. In OSCE, if you give after second or after third, don't worry. In OSCE. But in SBA, after third. Clear?
Okay,
Because SBA, I'm talking about final SBA, they need one option. Okay? But in
Mm.
OSCE, they can accept anything. Easy?
Okay,
But again, just follow them. So it will be after the third anyway. So this
okay,
patient, newborn, after 32 weeks, term. Before 32 weeks, preterm. So what is the difference? In term, you will dry, cover, stimulate. Dry, wrap, cover, stimulate. Okay? If preterm, keep undry. Don't dry. Clear? Okay. So what is the first action? Apgar score. Anwar,
Yes, doc.
how are you?
Alhamdulillah, I'm good, doc. How are you doing?
Okay. So Apgar, then newborn resuscitation. Okay. Then Apgar again. Then ABCD assessment, ROSC. Easy?
Yes, doc.
Again. What is number one?
Apgar score.
Apgar
And
score.
then
Newborn. Apgar score, how many points?
10 points.
10 points. Okay. So you are asking the examiner, I will assess Apgar score. What about A, activity? What about B, pulse? G, Gurmese. A, appearance. R, respiration. And the examiner can give you the parameter. You have only 0 and 2. 0 and
2,
don't think about 1. I mean, no activity or floppy. What does it mean?
0,
Active.
2.
2. Easy?
Yeah.
Otherwise, it will be 1. So, very bad or very good, 0 or 2. Otherwise, it will be 1.
1.
So, pulse, he said absent. What does it mean?
0.
More than 100?
1,
2.
2. 2.
You have only 0 and 2. So, otherwise,
Yes.
it will be 1. Okay? So, grimace, floppy. I said here floppy and I said here floppy. What is the difference? This one floppy, but I did not touch the patient. This one floppy, I'm pinching, I'm causing pain to the baby. Easy?
Yes,
Yes.
doc.
So this one, I did not touch the patient floppy. He's not moving. Then I check the pulse, absent. I tried to stimulate the baby, still floppy. Clear now? Okay.
Yes.
Appearance, blue or pale. Respiration, he's not crying. And his chest is not rising. So absent. Okay. So if the baby is crying, good. Okay. So otherwise it will be bad. Anyway, so I will assess Apgar score. What about blah, blah, blah? The examiner said absent, absent, floppy, blue, absent. The Apgar score is
0.
0
0 out of what?
out of
10.
10. The score 0 out of 10 should mention like that. Show the examiner the baby has severe, if 0 out of 1, not like 0 out of 10, right? Okay. So the baby needs
Resuscitation.
newborn resuscitation.
Newborn resuscitation.
Call neonatology team. Easy? Okay. What about A? What about B? In A, did I mention apply high flow oxygen?
No.
No, no need.
No.
Oxygen not important for newborn. Why? Because the accepted periductal oxygen after 3 minutes not
70.
important. Clear?
70.
For 3 minutes,
70 to
70%.
70.
It means the oxygen not important, right? If you mention the reversible causes, what are the reversible causes in newborn? Blood sugar, what else? Hypovolemia,
Hypovolemia,
pneumothorax, congenital.
Congenital.
congenital heart disease.
4 points. Congenital, not heart disease. They did not mention congenital heart disease. Congenital abnormality. Why congenital abnormality? It could be heart, it could be lung, it could be stomach, it could be the diaphragm. Easy?
Yes.
Okay. So in cardiac arrest, you will mention about I will consider the reversible cause and mention them. Okay. So I will assess Apgar score. The baby needs newborn resuscitation. What about airway meconium, suction? What about breathing? Is the chest moving? No. Do blah 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 blah. Is the chest moving? No. Do blah 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 blah. Is the chest moving? If no, you can repeat again. Clear, Anwar?
Yes, doc.
5 inflation breath, blah 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 blah. Still no, apply LMA. Easy?
Yes.
Okay, doc.
Apply LMA. If you apply intubation or LMA, you have to attach it to back valve mask, right? One
Yes, doc.
ventilation every
3 seconds.
3 seconds.
3
In pediatric,
seconds.
every 3 seconds. In adult, every 6 seconds. Okay, so you have 5 inflation breaths, 1 person technique. Failed, 5 inflation breaths, 2 person technique. Failed, you can repeat or you can start LMA with back valve mask. I wish it's clear. Then, is the chest moving? If yes, go for heart rate. Heart rate less than 60 or less than 100. Anyway, less than 100, you can start also newborn resuscitation. Yes. Okay. So they will give you something obvious. In heart rate, they will show you the monitor. You can verbalize the heart rate less than 60. Okay. Then what to do? 30 ventilation. Here in inflation, each inflation over 3 seconds, but in ventilation, every ventilation over 1 second. Clear?
Yes, but this will still be 3 times, doctor. And 3 seconds. For newborn and pediatric both, it is 3 seconds.
Regarding the chest moving, you will verbalize 5 inflation, each inflation over 3 seconds. Over, not every.
Okay.
Over,
Okay.
not every. It's a different.
Yes.
And the ventilation, each ventilation over 1 second. Clear?
Okay. Okay, doc. So it will be 60 per minute for newborn.
30
if one
seconds.
minute.
30
30
seconds.
seconds. Okay.
So 30
Okay,
ventilation, 30 seconds. Okay?
got it. Okay.
If you want to do for 1 minute, accept it also. Don't worry.
Okay.
If I say anything, it means I know what I'm doing. It means I know what I'm saying. Clear?
Okay.
So 30 seconds or 60 seconds, no problem. Accept it. Don't worry. Okay. The patient is still heart rate less than 60. What to do? CPR. So 30 ventilation, it's not CPR. Clear?
Yes, doc.
CPR, it means 3 to 1. 3 ventilation, 3 compression, 1 ventilation. 1, 2, 3, 1 ventilation. 1, 2, 3, 1 ventilation. Like that. Then check the heart rate is still less than 60. What is the next action? So the CPR without medication, then CPR with medication for 30 seconds. Then you will insert umbilical access, give adrenaline, extract blood for hematology, blah, 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 blah. As adult, give adrenaline 20 microgram. 20 microgram, more than pediatric? Newborn more than pediatric? Yes.
Yes.
20 microgram, okay? So in adult, 1 milligram. In pediatric, 10 microgram per kilogram. In newborn, 20 microgram per kilogram. Clear?
Yes, doctor.
Okay. Then what about heart rate? Still, they can give you still, or they can give you this one more ROSC. So this one still in cardiac arrest, this one ROSC. Easy?
Yes, doctor.
Okay. So here when you mention CPR for 30 seconds, blah 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 blah, I will consider the reversible causes like
Blood glucose, pneumothorax, congenital abnormality,
pneumothorax and
hypothermia,
hypothermia,
hypoventilation, sorry, hypovolemia.
hypovolemia,
So blood glucose, hypovolemia, congenital abnormalities, and
pneumothorax.
pneumothorax. Okay. Then, excellent guys, the patient has ROSC. I will assess Apgar score.
Apgar score.
So Apgar, resuscitation, Apgar. Easy.
Yes, doctor.
Then ABCD. So Apgar score. What about A? Blah, 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 blah. 2, 2, 2, 2, 2. Excellent. The Apgar score is 10 out
Of 10.
of 10. Then I will reassess the patient. Then you will start full assessment. What about airway? What about AFBO score? Is the airway patent? Then breathing, the 8 points. Then circulation 4 points. Then disability 4 points. And you can correct any abnormality. Easy?
Yes, doc. After Apgar, I will go to AVPU again. After Apgar, we will say APLS score and then go to airway.
Yes.
Okay.
So in after so Apgar, resuscitation, Apgar, then ABCDE. Easy?
Okay.
Okay. You have 30 seconds and 6 minutes.
sir, we can verbalize less than 100 or less than 60 heartbeats, sir.
60 better.
Okay, sir.
Less than 60, more than 100. Clear?
Yes, sir.
You can start, please.
Yes, doctor. Good morning. I'm Dr. Anwar, one of the data registrars. May I know your name and grades, please? I want one of you to take care of airway and one of the nurse for circulation equipment. Please prepare the equipment. We have a 34 weeks
The baby
child coming.
just arrived. The baby is 34 weeks.
Okay. I will start with assessing Apgar score of the child. How is the child activity?
Floppy.
Okay. What is the pulse of the baby?
Absent.
What about the grimace?
Floppy.
And appearance, skin color?
Blue.
Okay. What about the respiration?
Absent.
Okay, guys, we have a 34 weeks old baby with Apgar score 0 out of 10 points. He needs newborn resuscitation. Nurse, please announce the newborn resuscitation code and inform the neonatologist, and let us begin the newborn resuscitation. What about the airway of the baby?
Do you need to do anything with the baby now?
Yes, we will apply high flow oxygen to the baby.
No
I'm
need
sorry.
for oxygen.
We will announce the code and
What you will do with the baby?
we will dry wrap stimulate, and we
Okay.
will start the timer.
Okay.
We will keep in the warmer, and we will begin our assessment. How about the airway of the baby?
Meconium.
Okay, please, nurse, start suctioning. What about breathing? Is the chest moving?
Not moving.
Okay, please give 5 inflation breaths, 1% technique. Each inflation breath over 3 seconds. Is the chest moving?
Not moving.
Okay, please give 5 inflation breaths now, 2% technique. Is the chest moving?
Not moving.
Okay, please continue 5 more inflation breaths with 2% technique. Is the chest moving now?
Not moving.
Okay, please attach a supraglottic airway device. Let us start with LMA and attach to back valve mask and check for lung expansion. Is the chest moving now?
One ventilation every?
One ventilation every 3 seconds, please.
Yes, the chest is moving now.
Okay. Okay. Now we're happy with B. We will move on to C. What about the heart rate of the baby? Can we have it tracing? Okay, the heart rate is less than 60. This child is in cardiac arrest. We will start 30 ventilations now with our back valve mask, and every second should be one ventilation. So we will give for 30 seconds, 30 ventilations, please. Can we reassess the heart rate? Okay, it is still below 60. We will now do chest compressions for 30 seconds and provide one ventilation. So we will start 3:1 compression to ventilation ratio, please. Can we now reassess the heart rhythm? Okay, it is still below 40. Okay, please, nurse, insert umbilical access, and we will continue CPR for 30 more seconds. Insert umbilical access, take labs for hematology, biochemistry, blood gases, blood culture, and toxicology screen. We will give adrenaline 20 microgram per kilogram. What about the heart rate now?
What is the problem, doctor?
We will consider 4Hs. We will consider the signs of reversible signs of cardiac arrest in this baby. It may be either low blood glucose. It may be
The glucose is 1 millimole.
okay. We need to correct the glucose. Nurse,
What
please
other
start.
causes? What other causes?
It could be a pneumothorax. It could be congenital abnormality or hypovolemia. So please start IV fluids, and we will give 10% dextrose, 2 ml per kilo. We will start for this child. And we will start IV fluids. Okay. Congratulations, guys. We have ROSC. We will move to post-cardiac arrest care, and let us begin reassessment. What is the APGAR score of the baby? What about the
Active
activity
now.
of?
Active.
Okay, that's great. What about the pulse? It's more than 100. Okay. What about the grimace?
Good response.
Okay. What about the skin color?
Pink.
Okay. What about the respiration?
Crying.
Okay, that's fantastic. We have a 10 out of 10 APGAR score. The child is recovering. Can we assess AVPU score, please? The child is
The
crying.
APGAR score, the baby is crying.
Okay, can we assess the airway, please?
Patent.
Okay, please. Okay,
No.
let's move on to breathing. What about the SpO2 and RR?
SpO2 is 75. What is the accepted periductal oxygen? Now 3 minutes.
3 minutes, 70 to 75% is acceptable.
RR
So, okay.
is 40 now.
Okay, what about the trachea?
Deviated to the right side.
Okay, what about the neck veins?
Congested.
Okay, inspection of the chest,
Respiratory distress.
palpation,
Decreased expansion on the left side.
what about percussion?
Hyper resonant left side.
Okay, what about auscultation of lungs and heart sounds?
Decreased air entry left side and heart sound tachy.
Okay, guys, I think we have identified the reversible cause in this baby. Most likely it looks to be a tension pneumothorax on the left side of the chest. Please insert a needle in the second intercostal space mid-clavicular line and prepare for chest tube. Can we move on to circulation? What is the blood pressure?
Do you need to call in on?
We will call the neonatologist and the neonatal ICU team and the general surgery team.
Which? Cardiothoracic.
Cardiothoracic team.
Okay. Then
let's move on to circulation. What is the blood pressure like?
blood pressure is not recordable.
Okay. Any signs of life?
Yes.
Okay. What about the CRT?
CRT not recordable.
Okay. Peripheral pulses?
Weak.
Heart rate is still above 100?
Yes.
Okay, guys, we have another sign of instability in this age group. It is decreased systolic blood pressure and delayed CRT. Please start IV fluids according to red flags, and let us give bolus IV fluids to this patient. Can we move on to disability? What is the AVPU score?
Alert.
Okay, any signs of lateralization?
No.
How are the pupils now?
Equal reactive.
Did the blood sugar improve from the last time we
The
administered dextrose?
cardiothoracic surgeon, neonatology here.
Hello, sir. I'm Dr. Yasir. I'm one of the registrars here. And we had a child, 34 weeks, who came in with a APGAR score of 0 on 10. We performed newborn resuscitation on him, and we were able to get an APGAR score of 10 out of 10. We noticed left-sided pneumothorax. Okay, thank you.
Your time finished 30 seconds ago. Here, if you have no time, cardiothoracic cares about APGAR score.
No, pneumothorax.
No. You are calling him for Apgar score?
No.
You are wasting time.
Yes.
So start by the most important point. You still have time, go back.
Okay.
So, good morning, I'm blah, blah, blah. This baby has pneumothorax.
Okay.
I did needle thoracentesis.
Okay.
He needs chested drain cylinder tube in the fifth intercostal space or the second.
In the fifth, I
What
think
do
in
you
the
think,
fifth.
guys?
Fifth
Both.
intercostal clavicular line.
Second in the coastal space, mid-clavicular line.
That is
Can
for
be
needle.
two
For
of
the
them.
chest tube can be fifth, I think.
Chest
Yes.
tube, fifth intercostal space,
Yes.
just anterior to mid-axillary line, Sildinger technique.
Okay, chest tube, same as adult, but needle
It will be
thoracentesis
second.
is still in second intercostal space, mid-clavicular line. Okay?
Yes.
Okay.
Yes.
So the patient has hypotension. It could be because of tension pneumothorax or it could be
Yes.
because of hypovolemia. Clear? So
Yes.
I want you to think loudly to the examiner. You can say the patient has hypoglycemia, one of the causes of cardiac arrest. The patient has hypovolemia. The patient has pneumothorax. Clear?
Yes, doctor.
Okay. So you should correct all. Regarding fluids, I prefer any patient with pneumothorax. He has hypotension. It means obstructive.
Obstructive.
Any patient, whatever adult or pediatric, has pneumothorax plus hypotension, obstructive. If you give fluids, the fluids will worsen the problem. Clear?
But is this condition not preload dependent, doctor? We will give little bit, I mean, small
Unlikely,
amount.
listen, doctor,
Yes.
unlikely to find the two problems together. Unlikely to find tension pneumothorax with hypovolemia. Unlikely. Clear?
Okay.
So
Yes,
if
got
you
it.
find the pneumothorax in any patient and hypotension, obstructive until proven otherwise. Easy?
Yes. Yes, understood.
If the patient has pulmonary embolism and hypotension, obstructive until proven otherwise. Okay?
Yes,
So
doctor.
treat the problem. If you want to give fluids, give cautious fluids. It means,
Okay.
for example, in adult, instead of giving 500 cc, you can give 250. Easy?
Yes.
In pediatric, instead of giving 10, you can give 5 ml. But for the purpose of the exam, if you will give for pediatric, just mention 10 ml. Okay? Okay.
Okay.
So they will give you one problem only. If they give you pneumothorax, so you can insert a needle thoracentesis, then chest drain. Even you, if you want to insert chest drain, the examiner is silent, it means done. No need to wait for the cardiothoracic to insert, okay?
Yes.
Okay. Well done. I will give you 9 out of 10.
Thank you.
Next one, I think Omar.
Yes, Dr.
Yes. So this station 15 months. So infant or child?
Inf
Child. Infant 1 year. Child
15
1 year.
months, yes, yes, child, yes.
Okay. So this patient has cough. Okay. So
Yes.
cough, it could be airway, it could be breathing. But if he said stridor, hoarseness of voice, cough, so what is the problem?
Airway.
Airway. Okay. So you should verbalize the finding in airway. Yes. You should call the team in airway. Yes. You should do intervention in the airway. Yes. What is the intervention here? It will be dexamethasone, 0.15 milligram oral. Clear?
Yes.
Okay. Then prepare adrenaline nebulization, 0.5 ml per kilogram, maximum 5 ml. Easy?
Yes.
So, any case, fix this approach. Easy?
Yes.
Dexamethasone in airway and prepare adrenaline nebulization. Then, at any time you find severity, start nebulization, adrenaline. What are the
Okay.
severity? In airway,
Three.
the patient is not
Not alert.
alert. In breathing, severe respiratory distress, severe decrease their entry. Okay. The circulation, CRT, and the systolic blood pressure. Clear?
Yes.
And disability, again, the patient not alert. Okay. So if you find any of them, what you will do?
Give epinephrine nebulization.
Yes. What if you give the patient dexamethasone and then nebulize the adrenaline? Even he doesn't need nebulize the adrenaline. Don't worry. You can pass the station, okay?
Okay.
Okay. So you have 30 seconds and 6 minutes.
Okay, can I start?
Yes, please.
Okay. Good morning. I'm Dr. Omar, AD registrar. May I know your name and level, please? Okay. Are you APLS certified? Okay. Are you happy to take care of the airway? I need another nurse to take care of circulation.
Doctor,
While waiting
this
for
is my son. Please, please. This is my son.
Okay. Don't worry. Just be calm. I will assess and restrain your baby. I will assign one nurse to be with you. Any handover from the mother?
Yes, the baby has cough. The
Okay.
nurse said barking cough.
Okay.
Dry door.
Okay. Is the patient is conscious? What ABO score of the patient?
The baby is alert.
Okay. And there is what about the airway? Is the airway
Dry
patent?
door, barking cough, and hoarseness of voice.
Okay, this patient maybe have a croup. Please give the patient oral dexamethasone, 0.15 milligram per kg, and start also benzoyl nebulization, and please prepare epinephrine nebulization, 0.5 milligram per kg, maximum 5 ml. I will now check respiration. What about SpO2?
SpO2 is 80,
Okay, what about RR?
40,
Trachea,
central,
neck veins,
normal,
chest inspection,
respiratory distress,
palpation,
normal expansion,
percussion,
resonant,
auscultation of heart and lung.
severe decrease their entry.
Okay, please give the patient nebulized epinephrine as the dose I informed before, 0.5 ml per kg, maximum 5 ml. And I will check circulation. What about blood pressure?
Not recordable.
Any sign of life, look, listen, and feel.
Yes.
Okay, what about CRT
Not recordable.
and peripheral pulse?
Weak.
Okay, please insert 2 IV line, extract blood for hematology, biochemistry, temperature, blood gas, and infection screen. Please start IV fluid, 10 milligram per kg for the patient. Now I will check D. What about, is the patient still alert?
The patient is not responding,
Any
unresponsive.
sign, look, listen, and feel any sign of life?
No signs of life.
Okay, does the patient have cardiac arrest? Please activate pediatric cardiac arrest team. Please start high quality CPR with compression ventilation ratio 50 to 2. Please connect the monitor. What is the risk? Okay, please is BA. Also please give epinephrine 10 microgram per kg IV every 4 minutes. Already IV access is inserted. I will consider for H and for T. The most commonly cause here is hypoxia and hypovolemia because of the croup. Now 2 minute pass. I will check pulse in sign of life.
Yes.
Okay, now patient excellent have ROSC. I will assess airway. Is the patient is alert?
The baby is crying now.
Crying now. What about saturation and RR?
Normal.
Blood pressure?
Normal.
The patient random blood sugar?
Normal.
In a sign of lateralization?
Normal.
Pupils?
Normal.
What about temperature?
Normal.
I will expose the baby any other abnormality. Okay, please cover the baby. I need to hand over this patient to pediatric ICU team. Now I reassess the patient. What about the patient still alert?
Yes.
What about airway?
Okay, thank you. You still have
Okay.
1 minute 40 seconds, okay?
Yes.
You are doing well. So here, you don't need to give budesonide nebulization, okay? The patient already on dexamethasone. Just prepare nebulized adrenaline. Clear?
Okay.
Prepare to be ready. So the patient in airway, you said the baby has hoarseness of voice, stridor, broken cough. You said it could be croup, and you started medicines. Did you call anyone?
No, I should call the
After
anesthesia.
assessment, findings, and diagnosis, then
Call.
call. Did you call the pediatric ICU team?
No,
No.
I forget.
Okay. So the patient in breathing, you verbalized. I said you finished the assessment. Then I give you respiratory distress and severe decrease their entry and blah 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 blah. Did you mention the findings? No. Did you mention
Yes.
call anyone? No. Then you started nebulize the adrenaline.
Intervention.
So you missed findings and you missed the call. Clear? You
Clear.
did not show the examiner why you are giving nebulized adrenaline. Nebulized adrenaline in severity, right?
Yes.
So you should say the baby has respiratory distress, severe decreased air entry, and saturation 80. Okay?
Yes.
Then you can give the patient nebulized adrenaline. It will be logic. So you should call first and then give nebulized adrenaline. Okay?
Okay.
In C, you find the baby has hypotension. This is signs of instability as well. Okay? So you
Yes.
can give bolus, normal saline, maybe because of hypoxia. Sometimes hypoxia affects the heart. Hypoxia
Yes.
affects the heart. It will cause hypotension. It will cause myocardial depression or heart depression. Okay. Anyway, the patient in cardiac arrest, you did well, but did you give the baby 5 inflation breaths? No.
No, I forget.
Okay. Anyway, you are doing well. I'm trying to optimize your approach. The missed point, okay?
Yes.
You said I need to hand over this patient to pediatric ICU team. Did you mention for admission?
No.
No.
Mm.
So this patient needs admission. Any patient resuscitation, admission. How many categories for resuscitation?
One category.
One.
Four. Sorry, four. ALS, ATLS, APLS, newborn. So all of them need what?
Admission.
Admission. Patient came in resuscitation room. Admission. Now the patient is stable, the patient is conscious, the patient is laughing. Admission. Easy?
Yes.
Any
Yes, sir.
patient, resuscitation, admission. So I need to hand over this patient to ICU team. For what? For admission. Clear? For what?
Yeah.
Admission for what? You will do surgery?
No.
One
No.
management.
For
Observation.
treatment and observation, right?
Yes.
You should be clear. If the ICU team came to you, what do you need, doctor? Nothing. I want to call you. Is that logic? No.
Okay.
So you should be clear. What do you need from this specialty? So please, this patient for admission to continue treatment and observe. Easy?
Yes.
Okay. Patient has hoarseness of voice. Maybe he will not improve in the first hour. Maybe he will return again. Maybe he will deteriorate later, right? Okay.
Okay.
So you did well. I will give you 8 out of 10. Okay.
Okay.
Next one, Kalyan.
Hello, sir.
How are you?
Good, sir. Thank you.
So shortness of breath and less than 2 years. What is the likely problem?
Bronchiolitis.
Bronchiolitis. It could be pneumonia, yes, but when to say pneumonia? If the mother said sputum, if you find crackles crepitation, if you find high temperature, clear? If the
Okay, sir.
temperature 39.5, think about infection. Easy?
Okay, sir.
But if the patient has flu symptoms a few days ago and he has mild temperature now and crackles crepitation, think about bronchiolitis. Easy?
Okay,
So
sir.
you have two differential diagnoses. For the purpose of the exam, most likely bronchiolitis. Easy? Okay.
Okay, sir.
So in handover from mother, she will give you information about flu symptoms. Okay?
Okay, sir.
What is the treatment?
Clear the airway, high flow oxygen.
Yes. You have 30 seconds. What is the decision in the end?
Then the admission,
Admission for treatment and observation. Okay?
treatment and observation.
Yes. You have 30 seconds and 6 minutes. You can start.
Hello. Yes. Hello, I'm Dr. Kalyan, ED Registrar. I will be the team leader today. May I know your names and grades, please?
My son, doctor.
Please don't worry. We'll take care of your child. We will assign a nurse for you to take care of you and give you updates regarding the child. Can you tell me what happened?
Yeah, he has flu symptoms for 5 days and mild temperature, runny nose, sneezing, cough.
Okay, thank you. We will take care of the child. What's the AVP score of the child?
Alert.
Is the airway patent?
The airway is not patent. The patient has secretions in nose, mouth.
Please clear the airway, suction the nose and mouth, and apply high flow oxygen. And call pediatric ICU. Expose chest and connect all monitors. What's the oxygen saturation?
Saturation is 80.
Respiratory rate?
RR is 75.
Trachea?
Syndrome.
Neck veins?
Normal.
Any abnormality on inspection?
Respiratory distress.
Palpation?
Normal expansion.
Percussion?
Resonant.
Auscultation of lungs and heart?
Bilateral basal crepitation, wheezes, crackles.
Patient has bilateral crepitations and crackles, and respiratory rate is more than 70. And patient has low oxygen saturation. Continue high flow oxygen. Call pediatric ICU. And I will move to circulation. For the blood pressure?
Blood pressure is not recordable.
Look, less and feel any signs of life?
Yes.
What's the CRT?
Not recordable.
Peripheral pulses?
Weak.
Heart rate and rhythm? Patient heart rate is 77, and patient age is less than 1 year. Less than 1 year. So patient has bradycardia. Please optimize oxygenation. Give back wall mask ventilation. One ventilation every 3 seconds. Then call a pediatric ICU team. Then please insert to IV access. Collect blood for hematology, biochemistry, blood gases, blood culture, toxicology screen, and give IV fluids 10 ml per kilogram. Then I'll move to disability. What's the AVP score?
Unresponsive.
Look, listen, and feel any signs of life?
No signs of life.
So patient is in cardiac arrest. This is a pulseless electrical activity. It is a non-shockable rhythm. Please connect a defibrillator. We already inserted to IV access. Call pediatric cardiac arrest team and start CPR. Give five rescue breath and start CPR 15:2, 15 compressions to 2 ventilations with bag wall mask. And I consider 4 H's and 4 T's. In this case, most likely hypoxia because of bronchiolitis. Then continue CPR for 2 minutes. Give adrenaline 10 microgram per kg. 2 minutes passed. Any change in rhythm? Any signs of life?
Yes.
Excellent, guys. Patient achieved ROSC. Then I will reassess the patient. What's the AVPU score?
Crying.
Is the airway patent?
Patent.
What's the oxygen saturation?
9.4.
Respiratory rate?
Normal.
What's the blood pressure?
Normal.
What's the heart rate? What's the AVPU score?
Alert.
Yeah. Any abnormality in exposure?
Temperature is 38.
Temperature 38. Okay. Blood sugar?
5.
Okay. I will hand over the patient to pediatric ICU team. Patient needs admission in ICU for treatment and observation. Then I will reassess the patient. What's the AVP score?
Okay, thank you. You still have
Okay, sir.
35 seconds. Okay, this patient, 10 months, infant. So what is the indication in general to start back valve mask? Breathing and circulation. What is the indication?
Breathing and
Breathing,
Circulation.
circulation. When to start back valve mask? If the
Just
RR is low, if the heart rate is low, easy.
Okay, sir.
Breathing, circulation. When to start when to start the back valve mask in pediatric? 2 indications. Again, breathing, RR low, heart rate low. Okay. If the baby has RR, for example, 5, you started back valve mask, and the heart rate 77, okay? Then
Yes, sir.
already the patient on back valve mask, for example, right?
Yes, sir.
So no need to do any action, just resume back valve mask. Clear? Okay.
Okay,
If
sir.
the baby has heart rate 75, do you need back valve mask? No. No indication here, okay?
Okay,
So
sir.
you can just attach high flow oxygen non-rebreather mask, pediatric mask, okay? Okay,
Okay, sir.
non-rebreather pediatric mask. Okay, so you finished already airway and you cleared the airway, you called the team, okay? In breathing, did you verbalize the finding? Yes. Did you verbalize the diagnosis? No. Did you mention it could be bronchiolitis?
I mentioned during cardiac arrest, I think, sir. I didn't mention during breathing.
In breathing, in a live patient, you should mention the baby. The baby has blah 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 blah. You said crackles, crepitation. You did not mention wheezes. Why? You should mention both. Okay. So you should say
Okay.
the baby has hypoxia, crackles, crepitation, and blah 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 blah. He has flu symptoms few days ago, and in this age group, it could be. We have no evidence now. It could be what? Bronchiolitis. Okay.
Bronchiolitis.
Did you give salbutamol? No need, right?
Yes, sir.
Why? Because it could be bronchiolitis, but you did not mention bronchiolitis. Why you did not give salbutamol? Easy.
Okay, sir.
You have 2 options. If you will not mention bronchiolitis, you should give salbutamol. And this is wrong also. Easy.
Okay, sir.
If you mention bronchiolitis, you will protect the point of not giving salbutamol. I wish it's clear.
Okay, sir.
Will be logic, reasonable. Okay. In circulation, you did well. The patient non-recordable blood pressure. You ask about signs of life. The patient has signs of life. You give fluids, and then patient has cardiac arrest. You did well. So I will consider for H4Ts. The most likely problem is hypoxia, hypovolemia. Did you mention that?
Yes, sir.
Okay. So you did well. I'm just optimizing your approach. So this patient needs admission to continue treatment and observation. Okay. I will give you 8 out of 10. Thank you.
Thank you.
Basamat,
Yes, doctor.
how are you?
Fine, alhamdulillah.
So this patient has shortness of breath. More than 2 years. What is the likely problem?
Asthma.
Bronchial
Bronchial
asthma, not asthma. Okay. So what is the treatment for bronchial asthma? Breathing. What is the treatment?
oxygen,
Okay.
uh, Ventolin,
What is Ventolin?
bronchodilator.
Yes, don't say Ventolin. We know Ventolin, but don't say Ventolin. You can say salbutamol. Okay.
Okay.
So even if you will mention to the nurse, tell her salbutamol, not Ventolin. Clear?
Yes.
Okay, well done. So you will give salbutamol. It will be, you have two edges groups. Okay. So 2 to 5 years, 2.5 milligrams salbutamol. More than 5 years, 5 milligrams. So this one, 2.5. Regarding ipratropium bromide, it will be two doses also. You have 250 microgram and 500 microgram. Clear?
Yes.
So in this patient, 250 microgram. What else? Prednisolone. If the patient is alert, you can give prednisolone 30 milligram or 40 milligram. Any of them, don't worry. Oral. Okay? If the
Okay.
examiner said the baby is not alert or he said is vomiting, it means not tolerating oral. What you will do?
Give hydrocortisone, maybe
How much? 100.
100.
Less than 5 years, 100. More than 5 years, 200. Okay?
Okay.
So the patient at any time has cardiac arrest. The cause of arrest, hypoxia, hypovolemia. Okay?
Okay.
Someone will say hypovolemia yes. Two causes in pediatric. Hypoxemia, hypovolemia. Okay. You have 30 seconds and 6 minutes.
Good morning. I'm Dr. Basamat. I'm the AD registrar. Can you take care of the are you APLS provider? Can you take care of the airway? I need another nurse to be responsible about the circulation. We are expecting one patient with a breathing difficulty, 4 years old child. Is the patient arrived?
Patient arrived. Doctor, my son.
Don't worry, we'll take care of your son. I will assign one nurse to stay with you. Any hand over?
Yes, the baby has shortness of breath and he has no problem before.
It's okay, I will take care of your baby. Is the airway patent?
The airway is patent.
Is the baby conscious?
The baby is crying.
Okay, apply high flow oxygen and non-rebreather mask. Can you expose the chest? What is about the oxygen saturation?
Saturation is 80.
What about RR?
RR is 45.
What about the trachea?
Central,
What about the neck veins?
normal.
How about chest inspection?
Respiratory distress,
How about chest palpation?
normal expansion.
How about chest percussion?
Resonant.
How about auscultation of chest and heart?
Wheezes, bilateral.
Okay, this baby is in respiratory distress with low oxygen saturation, tachypnea, and wheeziness all over. Can you connect all the monitor, apply high flow oxygen for the baby, and prepare nebulization with bronchodilator salbutamol, 2.5 milligram, and consider giving the baby ipratropium 250 and prednisolone 30 milligram. And can we check the blood pressure?
Not recordable.
Any sign of life?
Yes,
How about CRT?
not recordable.
Peripheral pulses?
Weak.
Heart rate? So the baby is having, he's in shock and needs to put two wide work IV cannula, extract blood for hematology, biochemistry, blood gases, blood culture, and start IV fluid 10 milligram per kilogram IV bolus. How about the any ABVU score?
Our score is unresponsive.
Look, listen, and feel any sign of life.
No signs of life.
Uh, the baby in cardiac arrest. Can you please activate activate APLS team and start compression 15 to 2, and we'll consider the reversible causes, which is hypoxia and hypovolemia, and we will consider intubation for the patient, and we'll call anesthesia and pediatric ICU team, and give good CPR, connect the monitor, and I will intubate the baby and connect with back valve mask, and check for the success of intubation by checking the four areas as oxygen saturation and BCO2 and chest rise and chest auscultation. 2 minutes passed.
Did you give adrenaline?
I will give adrenaline 10 mic per kg.
2 minutes passed.
How about the pulse?
Yes, signs of life present.
Okay, there is signs of life. We achieve ROSC. I will reassess my patient. Is the airway patent?
Patent.
Patient is intubated. How about the oxygen saturation?
9.4.
How about the blood pressure?
Normal.
How about the baby is already intubated? Any sign of lateralization?
Normal.
About blood sugar?
Normal.
How about pupil?
Equireactive.
I will expose the whole body of the baby. Any abnormalities? How about temperature?
Normal.
I will endorse my patient to pediatric ICU team. I have a baby with ROSC after with bronchial asthma. He got cardiac arrest and then he got ROSC, and now he's stabilized. And if the pediatric ICU ready, I will reassess my patient. Is the airway patent?
Okay, thank you. Your time done. Okay, excellent, Basamat. So this baby has bronchial asthma. Okay. You did well in airway patent and in breathing. You found the patient has hypoxia. You said no oxygen saturation. You mean the patient has hypoxia, right?
I said low, but because I am in asthma attack, that's why you heard me wrong.
I am clarifying for people, not for you.
Yeah, no.
Okay. So the baby has wheezes, hypoxia. You can say it could be bronchial asthma. Did you mention the diagnosis in breathing?
Yes.
Okay, I'm not sure if you mentioned. I am sure you mentioned that in handover. Okay, but you should mention also in breathing in the first assessment before cardiac arrest. Anyway, the patient has blah 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 in this age group more than 2 years. It could be bronchial asthma. This is how to communicate. Okay, so you did give the patient salbutamol 2.5 milligram. You mentioned the dose the route nebulization. When you mention ipratropium bromide, you said consider. No, give, not consider. Clear? Because even if the patient is improving, you have to give. Clear, Basama? Okay.
Yes.
So you said 250, but you did not mention microgram. This is not good. So 250 microgram important because what if the nurse give high dose, right?
Yes.
So 250 microgram. What? Nebulization. Should mention nebulization. Okay. Even you mean nebulization. Even you know it's a nebulization. Even it's already known nebulization. You have to mention that. Clear? Then prednisolone oral. You should mention that. 30 milligram or 40 milligram oral. Well done. Then if the patient has cardiac arrest, you forgot to give adrenaline, right? Okay. So once the patient has BA, you should mention the patient has non-shockable rhythm, cardiac arrest, non-shockable rhythm, BA. Then you can give adrenaline 10 microgram per kilogram according to Whitfield. And the fluid also 10 ml per kilogram. Okay, I will give you 8 out of 10. Well done, thank you. Muzammil,
Sound, sir.
how are you?
Alhamdulillah, fine, sir. How are you?
I'm fine. This patient has shortness of breath and he has foreign body in mouth, right?
Yes, sir.
Okay, so shocking. So can you see foreign body in the scenario? It means foreign body only. Okay,
Yes, sir.
so if they said stridor, because of the foreign body. If they said any hoarseness of voice or any blah 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 in the because of the foreign body. So don't think about anaphylaxis. Don't think about differential diagnosis. I wish it's clear.
Yes, sir.
Okay, so you have a general approach for shocking. In general, we say A, B, C, D, E, but here in shocking, you will say A, B, then go back, A, C, then go back, A, D, then go back, A, E. Easy?
Yes, sir.
Okay. You have three possibilities in the airway. How many possibility?
3 possibilities.
Patient coughing, effective, number one. Number two, coughing, ineffective, number two. Number three, unresponding, means cardiac arrest. Easy?
Okay, sir.
So two possibility alive, one possibility
Ineffective.
cardiac arrest.
Cardiac arrest, sorry.
Number one, coughing
Cough
effective, it means alive.
alive.
Number two, coughing ineffective,
Ne-
it means alive.
alive.
Number three, unresponding, it means cardiac arrest. Clear?
Yes, sir.
So the key of this station in airway, you can write the questions of airway. Is what is AVO score? Number one, what is AVO score? Anytime you will go to airway, you should ask these questions. Are you writing?
Yes, sir.
Number one, what is AVO score? Number two, is the airway patent? The examiner will say no. Then ask, any foreign body? You can ask any station, any foreign body? No, this is station because they mention foreign body, right?
Yes, sir.
Okay, so you will ask, any foreign body in the mouth? Yes. Is it visible? Yes. Am I able to remove? No. Is the baby coughing? Yes. Effective? Yes. Then we finished now. What? We finished what?
Cough effective. Part 1.
We finished what?
Full assessment.
After
8.
full assessment,
Finding.
the patient has foreign body in the mouth.
Call a pediatric ICU team and anesthetist team. May
Then
require
your intervention. What is your intervention?
encourage cough.
Baby cough. Easy.
Yes.
Can you see if you are following my approach?
Yes,
This
sir.
is the general approach. I'm the only one created this approach, and I'm sure all people they are following me, even teachers, even instructors all over the world. Okay, so just you are in airway, you are in airway. You will finish full assessment. It means you will ask these questions. Then verbalize the patient has foreign body, visible or not visible.
Not visible.
Visible. Okay, the baby has active, effective cough. Then call anesthetist, pediatric ICU team, including anesthetist. Then baby cough. Easy?
Yes, sir.
Okay, then you will go for breathing. The baby is coughing. You have nothing else to do. In the meantime, you are doing breathing, right? Okay.
Yes.
Connect all monitors, expose the chest, connect all monitors, then ask about the 8 points.
8 point.
SB2, blah, 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 blah. Then go back to airway. Ask the same point. What is
AV.
Alpha score? Is still beta? Still alert? Clear? What is
Yes, sir.
Alpha score? Still alert? What about the airway? Patent? No. Is the foreign body still visible? Yes. Am I able to remove? So you will ask the same questions. He said the cough is effective. What you will do?
Encourage cough. The
Baby,
is
baby.
having for call the pediatric ICU team and
Already called. No problem. You can ignore this point to save time. Clear?
okay, sir.
Okay. So after airway, you will go for circulation. You will ask about the 4 points. Finished. Normal. You will go back for airway. Ask the same questions of airway. Easy?
Yes, sir.
Okay. Then, for example, you finished E exposure. You find everything normal now. I need to hand over this patient to?
Pediatric ICU team.
Okay, and I will assess the baby. I will ask the same question of airway. In the end, he said the cough is ineffective. Ineffective. What to do?
Give 5 back blows and 5 abdominal thrust.
Yes. So in 4 years, it means infant or child?
Child.
Child, it means abdomen. Okay? So remember that. Which is first, chest or abdomen?
Chest.
Chest first, abdomen second. Which is first, infant or child?
Infant.
So infant, child. Easy?
Yes, sir. Yes.
So chest, abdomen, infant, child. Okay? So you will say 5 back blows. In the exam, you find the mannequin like that. You will hold the mannequin by one hand and the other hand on the back. No need to be aggressive. We are acting just by hand, gentle on the back. 1, 2, 3, 4, 5. Then abdomen thrust. 1, 2, 3, 4, 5. Easy.
Okay.
Then you will ask about the airway again. So after you ask about the airway, if you find the baby coughing still ineffective, you will repeat. What if you find improved, it became effective? What you would do?
Cough effective. Then I'll ask if is the foreign body
Baby
visible?
cough, baby cough. Already you ask, and
Okay.
he said the cough effective. What you will do?
Baby cough.
Baby
Encourage
cough.
cough.
So you have 3 possibilities. For the first possibility, what is the intervention? Baby cough.
Cough.
The second possibility, 5 back blows, 5 abdomen thrust. Okay?
Oh.
The third possibility, cardiac arrest, like any arrest. So after that, the examiner will say unresponsive. What you will say?
Look, listen, and feel any signs of life.
No signs of life.
So start high quality CPR and call the pediatric
No,
risk.
no. Why you are always jumping to intervention?
Okay.
Full assessment. You ask, look, listen, and feel. It means full assessment. I said no signs of life. Huh?
Patient
Will
is in
find.
Finding. What is the finding? What did you find? Baby in cardiac arrest. Call.
pediatric resuscitation team.
Activate pediatric cardiac arrest call. Then intervention, start 5 risk breaths and high quality CPR. You can do both together? Yes.
Yes.
Easy?
Yes.
So just follow the general approach. Don't jump to intervention. Okay?
Yes, sir.
When the examiner say unresponsive, look, listen, and feel. If you say look, listen, and feel, you're assessing the patient in alive or in cardiac arrest. Easy?
Yes.
Then show the examiner what did you find. Then what you will do, call, then intervention. I wish it's clear.
Sure.
Okay, you have 30 seconds and 6 minutes.
Good morning. I'm Dr. Muzamil, the ID registrar. May I know your name and grades, please? I do both APLS and thank you. We are receiving one patient with breathing difficulty, choking on a foreign body. Please prepare bed flag sense. Has the patient arrived?
Doctor, this my son, he has something in his mouth. He was playing with toys.
Oh, I'm Dr. Muzamil, the ED registrar. I will take care of your baby. I'll assign a nurse for you so that they will update you. What had happened? Can you just brief me?
I told you, doctor.
Yeah. We'll take care of you. What is ABPU square?
The baby is alert, leaning forward, standing, leaning forward.
Okay. Is the airway patent?
Not patent. The baby has foreign body.
Is the foreign body visible?
Yes.
I'm able to remove foreign body.
No.
Baby is coughing.
Yes.
Please call as the patient have foreign
Ask
body.
effective or ineffective. Did you write? You did not write.
Right, sir.
If you wrote, why you did not ask?
Yeah, I'm going fast. I missed. I wrote already. Is the cough effective?
Yes, effective.
Okay. As the patient is having foreign body and it is causing breathing difficulty, please call the cardiac ICU, pediatric ICU team, and anesthetist may require, the baby may require early intubation. Please, baby cough. Expose the chest and connect to all the monitors. What is SpO2? What is the respiratory rate?
94 and RR is 45.
Okay. What is how is the trachea?
Central.
Neck veins?
Normal.
Inspection of the chest, palpation of the chest, percussion of the chest, auscultation of heart and lungs?
Normal.
Okay. What about how is the ABPU score now?
Alert.
Is the airway patent?
No. Foreign body.
Is the foreign body visible?
Yes.
Am I able to remove the foreign body?
No.
Is the baby coughing?
Yes.
Please, baby cough.
Ask effective or ineffective.
Yeah. Is the cough effective?
Effective.
Please, baby cough. Going to the circulation, how much is the blood pressure, heart rate, CRT, and peripheral pulses?
Normal.
Okay. Please, sister, put to IV bore cannulas, extra blood for hematology, diagnostic blood gases, blood pressure, and toxicology screening, and give fluids 10 ml per kg body weight as per the wet flag signs. How is the ABPU score now?
Alert.
Okay. Airway, how is the airway patent?
No.
And is the foreign body visible?
Yes.
Am I able to remove the foreign body?
No. Very far.
Okay. How is the cough present?
Yes.
Is the cough effective?
Yes.
Please, baby cough. Going to disability, how is the pupils? Any lateralizing signs?
Normal.
ABPU score?
Still alert.
Okay. And what is the sugars?
Normal.
Okay. And coming back to the airway, what is ABPU? Patient still alert?
Yes.
Okay. Is the airway patent?
No.
Is the foreign body visible?
Yes.
Am I able to remove the foreign body?
No. Very far.
Is the baby coughing?
Yes.
Is the cough effective?
Effective.
Please, baby cough. Expose the complete body and look for any abnormalities. What is the temperature?
Temperature normal.
Has the pediatric ICU team arrived? Any anesthetist arrived? I want the hand over the patient to them. I will reassess the patient again. What is ABPU score now?
Alert.
Is the airway patent?
No.
Is the foreign body visible?
Yes.
Am I able to remove the foreign body?
No. Very far.
Is the baby coughing?
Yes.
Cough is effective?
No, he's tired now. Fatigue.
Oh, sat down. So I will give 5 back blows and 5 abdominal thrusts. Is the cough effective now?
Ask is the AVO score. Ask the same questions of airway.
Okay. How is the ABPU score now?
Still alert.
Is the airway patent?
No.
Is the foreign body visible?
Yes, visible.
Am I able to remove the foreign body?
No.
Is the baby coughing?
Yes.
Is the cough effective?
No. Still not effective.
Still not effective? Okay. So I will give another 5 back blows and 5 abdominal thrust. I will assess again. What is the ABPU score now?
Alert.
Is the alert? Okay. Is the airway patent?
No.
Is the foreign body visible?
Yes.
Am I able to remove the foreign body?
No.
Is the baby coughing?
He's unresponsive now.
Look, listen, and feel. Any signs of life?
No.
Patient is in cardiac arrest because of hypoxia, because of the foreign body in the mouth. Please call pediatric ICU team and anesthetist and a pediatric resuscitation team. Please start high quality CPR. First, give 5 rescue breaths with high quality CPR, 15 compressions followed by 2 breaths, and the heart rate. The pulse is not there. This is a non-shockable rhythm. Please give adrenaline 10 microgram per kg body weight and continue CPR with 15 compressions followed by 2 breaths. 2 minutes pass. Look, listen, stop, switch, analyze the rhythm. Any signs of life?
Yes.
Good, excellent. We achieve ROSC. Let me assess the ABPU. How is the alertness?
The baby is alert.
Okay. Is the foreign body visible?
Visible.
Am I able to remove the foreign body?
Yes, it's very near now in the hub of the mouth.
I will remove the foreign body with Magel's forceps. Okay. Foreign body successfully removed. How much is the SpO2?
Normal.
Respiratory rate?
Normal.
Blood pressure?
Normal.
Heart
Okay.
rate?
So what you will do?
Okay. I will hand over the team to the ICU.
Why?
Heart rate 77.
Why? Why you will give to ICU team? Why?
For admission, for observation and treatment.
Okay, thank you. Okay, thank you, Muzammil. You did very well. No need to be very fast. If this will affect you, will let you to miss some points, try to be calm, okay?
Yes, sir, today.
So, you have 8 minutes. 8 minutes more than enough to finish your time, finish your task, finish your checklist, finish every point, okay? Try
Yes,
to
sir.
be concise, no problem. Try to be simple and not very slow, but at least normal, okay? So here, the same questions of airway you will ask every time you go to airway. Easy.
Yes, sir.
You finished airway, then call, then assessment, find the call intervention, okay? So you did well. After ROSC, you have to start by airway again, the same questions. Okay.
Yes, sir.
Well done. I will give you 9 out of 10. 9 out of 10. Thank you.
Dr. Hani,
Yes, please.
if the patient from the start is have an effective cough, after I finish the 5 back blue and chest thrust, I will again assess AVPU or I will go to B breathing.
If you are asking the patient for coughing, so nothing else to do. So you will go for breathing. But if the patient has ineffective cough in airway, in the first airway, this is your question. Then
Yes,
you will do 5 back blows and then 5 abdomen thrust. Then go for airway again. Don't go for breathing.
airway again. Okay.
Yes, because it's a serious, ineffective. It means unstable. Clear?
Mm,
But if the
yes,
patient is coughing and the effective is still reassuring, you know,
yes.
you have time to go for breathing. Then you can go back for airway. Easy?
Okay, thank you.
Yeah. Okay. Next station, I think Giovanna,
Yes, sir.
how are you?
Yeah, good. Thank you, sir.
Okay, this patient has vomiting diarrhea. It means which system?
GIT and urogenital.
You have airway GIT. Do you have system
Yes.
GIT in resuscitation?
No, sir.
Which system?
In resuscitation?
Which system, guys?
C.
Circulation.
Okay,
Circulation.
circulation. Fine.
Circulation, not GIT, right?
Okay, sir.
You have A, B, C, D, E. We are not in history taking here, right?
Okay, done.
So please take care. So you have airway, breathing, circulation, disability, exposure. So vomiting, diarrhea, you have 2 systems. airway and circulation. The main system, circulation. Why I said airway? Because maybe the patient has vomiting or vomitus in his airway, and then you will clear. Clear?
Okay.
Once you clear, no problem in airway. But vomiting diarrhea, the patient has problem, serious in circulation. You are expecting dehydration, hypovolemia, hypotension, I mean, maybe cardiac arrest, maybe the patient has electrolyte imbalance. So maybe they will give you ECG for hypokalemia, okay? Or maybe they will mention blood results, the potassium is 1 millimole, right? So the treatment, you should give potassium chloride. Enough. So it will be 10 millimole over 1 hour. Easy?
Yes, sir.
So this patient treatment, fluids and potassium chloride, nothing else, okay?
Okay, sir.
And the supportive management, for example, if airway not patent, you can clear airway and then in any vomiting, guys, try to avoid oropharyngeal. Any vomiting, try to avoid oropharyngeal because it will increase the vomiting. If the patient has vomiting, it means he has airway reflexes, right?
Yes, sir.
So take care. Once you clear the airway, if you put the oropharyngeal, he will vomit again. So nasopharyngeal, no problem. So clear the airway, nasopharyngeal, and non-repressional. You have 30 seconds and 6 minutes.
Good morning. I'm Dr. Jeevna, ED Register. May I know your name and level, please? I need one more nurse. Are you comfortable in managing airway and breathing? Nurse B, are you comfortable in managing circulation? Today we are about to receive a 2-year-old
We
baby
are
with
waiting
vomiting and
for
diarrhea.
patient with vomiting diarrhea. I don't care about his name or age. Mention the problem only. Save time.
Okay. We are about to receive a patient with vomiting and diarrhea.
Patient
So
arrived.
please prepare. Any handover from the ambulance crew?
Yeah, the patient has vomiting diarrhea for 3 days.
Okay. How is the APLS score? Is the patient conscious?
Unresponsive.
Look, listen, feel any signs of life?
No signs of life.
Okay, guys, patient is in cardiac arrest. Please call a pediatric resuscitation team and activate the cardiac arrest code. And please begin a high quality CPR with 15 compressions and 2 respiratory rate. And please insert 2 large IV bore cannulas and take blood samples for hematology, biochemistry, blood gases, and give IV fluids 10 ml per kg body weight, and prepare adrenaline also. Okay, 2 minutes passed. Any signs of life? Any change in rhythm?
You said prepare or give.
Adrenaline 1 mg, 10 microgram per kg.
You said
Yeah, we have
prepare
to give.
or you want to
We
give.
have to. We can give now, sir, after 2 minutes.
Okay, not after 2 minutes, immediately.
Okay, sir.
Okay,
Give
so
adrenaline
we
10
should say
microgram per kg
give
IV.
adrenaline 10 microgram per kilogram, according to what flag.
Give adrenaline 10 microgram per kg IV bolus. Okay, continue the CPR. 2 minutes passed. Any change in?
What is the problem, doctor? I'm the junior nurse.
Okay, a baby is having vomiting and diarrhea. It could be mostly due to a hypovolemic shock, leading to a cardiac arrest.
Okay, so
So we'll continue with the CPR.
the blood results are available now.
Okay, yeah. How about the blood gases? What about the pH?
pH is 6.9.
Okay, what about PCO2 and PO2 levels?
Abnormal.
Okay, what about electrolytes, sodium, potassium, and chloride?
Potassium is 1 millimole.
Okay, what about lactates and bicarb?
Normal.
Okay, guys, as per the report, the patient is in hypokalemia. So, with after considering 4Hs and 4Ts, we will be giving a 10 millimoles per kg potassium chloride to the patient, and continue the CPR.
How much
along
potassium chloride?
10 millimoles per kg. 10 millimoles potassium chloride over 1 hour.
Okay. In cardiac arrest bolus.
Yes, sir. Okay. And So please give 10 millimoles potassium chloride IV bolus and continue the high quality CPR. 2 minutes passed. Any
Yes.
change in any signs of life? Any change in rhythm?
The patient has signs of life.
Okay, guys, congratulations. The patient have achieved ROSC, and I'll reassess the patient. What about the AP score now? Is the airway patent?
Crying. The airway is patent.
Okay, I'll expose the chest and look to the motor. What about the saturations?
Saturation 94.
Respiratory rate, trachea, neck veins.
Normal.
Okay, on in chest, inspection, palpation, percussion, and auscultation of heart and lung findings.
Normal.
Okay, I'll move to the circulation. What about the blood pressure? Please, what about the blood pressure?
Blood pressure normal.
What about the CRT, peripheral pulses?
Normal.
What about the heart rate and the cardiac rhythm now? Okay, I can see a patient is having 77 beats per minute.
This is the ECG from the ambulance crew, doctor. Before
Okay,
conversation.
in ECG, we can see that there is a prominent U waves. It could be related to a hypokalemia. So this hypokalemia caused a cardiac arrest to this patient. And already we have given a potassium chloride IV bolus. So we'll continue with the treatment. And I'll move to the disability. How about the AP score now?
Alert.
And how about the pupils?
Hyperactive.
Any lateralizing signs?
Normal.
What about GRBS?
Normal.
Okay, on exposure, any temperature?
Normal.
About the any abnormal findings? Okay, has the pediatric ICU team has arrived? I'll give a handover to the ICU team
For what?
for admitting this patient, as the patient had a cardiac
Okay,
arrest
thank
with
you.
hypovolemia.
Thank you. Your time almost finished. You still have 30 seconds. Okay, thank you, Jafan.
Yes, sir. Thank you.
Okay, so this patient, if he has vomiting, you will clear the airway and the nasopharyngeal and then non-rebasal mask. In breathing normal, in circulation, you find the patient, blah, blah. So here in the beginning, I change the approach. So the examiner can give you patient alive, okay? Or in cardiac arrest from the beginning, okay?
Yes, sir.
So if you find the patient has cardiac arrest in the beginning, don't ask about 2 minutes until you finish everything. You are in a hurry to ask about 2 minutes. Why? To check if he has a ROSC, right?
Yes, sir.
He will get ROSC without correcting the reversible cause. If the patient has hypokalemia and you did not treat hypokalemia, he will get ROSC.
No,
The
sir.
patient will get ROSC. You did not check the rhythm. You did not give adrenaline. The patient will get ROSC if he has shockable rhythm, VF or VT, and you did not give shock. Do you think he will get ROSC?
No.
Do you think he will get ROSC without inserting IV access? No. Why you are asking 2 minutes about? Why? Why? Do you think the patient will regain consciousness or ROSC circulation without doing anything? Magic? Is it magic? No. Okay. So you should do something for the patient. Okay.
Yes, sir.
So inserting two IV access, extractive blood for blah blah blah, gives the patient fluids. You should consider the reversible causes according to the scenario. Okay. In real practice, you should consider 4H40s completely. But for the purpose of the exam, you have no time to verbalize everything. Okay. So according to the scenario, so you can say you will consider 4H40s. The patient has vomiting diarrhea. It could be hypovolemia. It could be hypokalemia. Easy.
Yes, sir.
Okay. Then you will give the patient normal saline, 10 ml per kilogram according to it flag. Then ask about the blood gases and the blood results. And to correct, you will give in cardiac arrest bolus. Okay.
Sir,
So
I thought that we are going with circulation and we have
forget
just extracted
circulation.
players. No.
Forget
Yeah.
circulation. If you have cardiac arrest, forget A, B, C, D, E. Clear?
Yes, sir. We have taken blood samples just at the first cycle itself, no? So I thought to ask in the second, after 2 minutes passed, regarding the blood gases
Yes,
report.
I'm confirming now. So you have two possibilities, whatever in the real practice or in the exam. Maybe the first possibility, a live patient or cardiac arrest patient. If a live patient, you will follow A, B, C, D, E. If the patient in cardiac arrest, forget A, B, C, D, E. Easy?
Yes, sir.
Okay.
That I understood, sir. The doubt
Okay,
is
doctor,
that
we
we
have no
have,
time. Sorry, we have no time. Just listen to me, okay? So
yes, sir.
you have two possibilities, A, B, C, D, E, and cardiac arrest. If the patient is alive, he has signs of life, then ask about airway. So if the patient is alive, you will follow this slide. If the patient is in cardiac arrest, forget this slide. Easy? Okay.
Yes, sir.
So in cardiac arrest, you have only 2 points. Number one, high quality CPR, it means number one, chest compression, number two, ventilation. Done. Nothing else. Okay. And consider for H40s and correct the abnormalities. How to correct the abnormalities? If the patient has hypovolemia, give fluids. If the patient has non-shockable rhythm, give adrenaline. If the patient has shockable rhythm, give shock. Then you can ask about 2 minutes passed or not. The patient will not return to life until you give adrenaline if non-shockable or give shock if shockable and give fluids, high flow oxygen, and correct other abnormalities. Easy?
Yes, sir.
Okay. So I will give you 7 out of 10. 7 out of 10. Okay. Next one, Ali.
Yes, sir.
Hello, sir. Sir, sorry, sir.
Yes, please.
Sir, I have a doubt. Should we check magnesium and also correct magnesium along with potassium correction? Not important.
Not important. You can give magnesium, no problem. Any hypokalemia, you can give magnesium.
Okay, sir. Thank you.
So you can say give potassium chloride, blah, 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 and give magnesium, no problem. You want to mention, okay. You don't want to mention, it's not a big issue.
Thank you, sir.
Welcome. Okay. Ali?
Yes, sir.
Okay, this patient is seizing. So what is the most
Dis
relevant system?
disability.
Disability. Okay. So history different than resuscitation. So the system here seizing, we are talking about disability.
Disability.
Okay, you will catch the problem in disability. You will start the algorithm in disability. So the algorithm here, also the previous algorithm, 2021, the previous one, it was like 2015, I think something like that. I was advising people after 5 minutes or after 10 minutes, it's not a big issue. They make 2021 same idea. The same advice for old batches, they did that in 2021. They make it flexible.
Okay, sir.
It means every 5 minutes, every 5 minutes, every 5 minutes, every 5 minutes, like that. Okay. So
Yes.
when to start the algorithm? After how long?
5 minutes.
5 minutes.
Yes.
So in disability, it's up to you. You want to start in first disability? Okay. You want to start in second disability? Okay. But whatever, you will start in the first disability or in the second disability, you should verbalize 5 minutes past, the patient is still seizing. It could be,
Status epileptics.
yes. So once you
It-
mention that whatever in first disability or in the second disability, you should mention 5 minutes past. Okay?
Okay.
Okay. Then you will give the first dose. How many lines? We have 3 lines.
Yes.
How many
Two,
lines? We have three
three.
lines.
First line is two doses of benzodiazepam.
Yes, please wait.
Okay,
So
sir.
we have 3 lines. First line, second line, third line. Third line, already rapid sequence induction. I will not talk about that. So we have first line and the second line now. First line, 2 doses of diazepam. 5 minutes, 5 minutes. Done. Then second line, 3 medication. So the first line, how many medications?
Two
Two
medication.
medications. The second line, how many medications?
One of three.
Yes, three medications. Okay.
Yes. Yes.
So in the first line, mandatory to give this one. If failed, mandatory to give this one. But in second line, if the first one failed, you have two options. Either to go for the second medication or either to give
Rod
third line.
Okay.
Easy?
Easy.
Okay. So once the patient arrive to ER, you will do A, B, C, D, E. Okay. So
Okay.
what is the first action?
I check the airway.
Can you see the mouse?
Yes.
A, B, C. Okay.
ABC. Yes.
Then after ABC,
I will check blood D, disability, blood glucose.
disability, blood glucose. So blood
Yes.
glucose in disability or before airway?
After airway, disability.
After C, disability.
Yes. Yes.
So some not knowledgeable doctors, they will say check blood sugar first. Why? If the patient has problem in airway and the problem in glucose, what is the first action?
To correct airway problem.
Correct airway. Okay.
Yes.
So why I will check blood sugar? If the patient has hypoglycemia, the patient will not die from hypoglycemia. When the patient die from hypoglycemia, if the patient has sepsis,
Yes,
easy.
sir. Easy.
The only case killing the patient with hypoglycemia, sepsis. Why? Normal hypoglycemia without sepsis, once you give the patient dextrose, the blood sugar maintain, for example, 200 milligram, or I mean, for example, 7 millimole, okay? Whatever you are
Okay.
using, milligram per dl or millimole, okay? I mean normal, and it will maintain normal. But unfortunately, with sepsis, you give the patient dextrose, the sugar normal, then fall within few seconds. You give dextrose again, raise, then fall. Clear, guys, this point? So the cause of this, not hypoglycemia, the cause of this is
Sepsis.
sepsis. Okay.
Yes.
So don't care about hypoglycemia now. Even if the patient has sepsis, you have to correct the airway first. Okay.
Yes.
So A, B, C. After C, check blood glucose. When to treat blood glucose? If less than
3 millimole.
3. The normal 4 to 8. It means 3.5 abnormal, but no need. Don't treat. The blood
Okay, sir.
sugar is 3 millimole. You will treat?
Less than 3 millimole.
I'm talking about 3. You will treat?
Yes. No.
No. Treat, don't treat. They said
Okay.
less than?
3 millimole.
Yes. So if, for example, 2.9. Easy?
Yes. Easy.
Okay. Anyway, you will manage the patient. The patient is seizing. No need to do anything. Just oropharyngeal, nasopharyngeal. If you cannot open the mouth because clenching the teeth, don't open the mouth. Don't force. Some doctors, they are breaking the teeth. They are forcing by tongue depressor or forcing by laryngoscope. Why? You have mouth and nose, right?
Yes.
You have mouth and nose. The patient is clenching his teeth. Go for the nose.
Yes.
Hypothetically. Okay. So, number one, clear the airway, nasopharyngeal. Someone will say left lateral position. No, left lateral position after disability. After disability. Why? Because you want to see the patient has a problem, like for example, resident intracranial pressure, unequal pupil, maybe he has neck injury or head injury. Clear now?
Yes, clear.
It would be contraindicated. So, anyway, to be simple, manage airway, breathing, circulation, disability, and blah, 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 blah. Once you finish everything, you will find the patient is seizing. Then you will start the first line benzodiazepine. Then in the second disability, in the next disability, give again diazepam. So the dose 0.1 milligram per kilogram. Okay.
Okay.
IV. Then next day, you find the patient still seizing, you will give levetiracetam. Levetiracetam here over.
5 minutes.
So here midazolam
5 minutes.
bolus,
Bolus, yes.
lorazepam bolus, lorazepam bolus. Okay. Then
Yes.
regarding the levetiracetam, Infusion or
Bolus.
no, infusion
Oh,
over
oh,
5 minutes. So
okay.
lorazepam bolus, but levetiracetam infusion, phenytoin
Oh,
infusion,
yeah, yes.
phenobarbital infusion,
Infusion.
rapid sequence induction bolus. Okay.
Okay, sir. Okay, sir.
So the second line only infusion. Any of them. I said any of them. You can start by phenytoin. I'm talking about the second line. You can start by phenytoin. Yes. You can start by phenobarbital. Yes. You can start by levetiracetam, yes. But because they said levetiracetam, better to start by levetiracetam, okay?
Dose is 50 microgram. Can I say that?
30, 30
30.
milligram per kilogram.
Okay, sir.
Levetiracetam, 30 milligram per kilogram over 5 minutes. Phenytoin, 20 milligram over 20 minutes.
Okay, sir.
Phenobarbital, 20 over 5. So
Yeah.
all of them 5 minutes, 5 minutes, 5 minutes, 5 minutes, 5 minutes, except phenytoin over.
20 minutes.
So everything 5 minutes, except phenytoin. I wish it's clear.
Yes, clear, sir.
So if you ignore the phenytoin, no one will blame you. If you ignore the phenytoin, it means everything 5 minutes. I wish it's clear.
Yes, sir.
Okay. So you have 30 seconds and 6 seconds.
Okay. Hi, hello. I'm Dr. Ali. I am the team leader today. May I know your name and level? Nice to meet you. Are you APLS provider? We are expecting a patient with a boy with seizing and drowsiness and fever. Can you take care airway? I need another nurse to take care of circulation. Please call adult pediatric
Patient alive?
patient. Any handover of the ambulance crew or the mother?
Yes, doctor. This is my baby. He has no problem before. He started seizing just now, and I did not give him anything.
Okay, please be calm. We will take care of your child. We'll shift him to a station. Is there any history, any previous history of any medicine or medication?
I told you already.
Okay, sir. Be calm, please, nurse. Accompany the mother. We will update her. So I will assess the patient now. What is the ABO score?
The patient is seizing.
Okay. Is the airway patent?
The airway is not patent.
Please, nurse, clear the airway, insert NBA, and apply high flow oxygen. Meanwhile, I will go to assess the breathing. Exposed chest, attach all monitors. What is the SpO2?
Normal.
RR,
Normal.
neck vein,
Normal.
trachea,
Normal.
inspection and palpation of the chest,
Normal.
percussion and auscultation of the lung and heart.
Normal.
Okay, thank you. I need to assess the circulation. What is the blood pressure?
Blood pressure is low.
Okay. Okay. What about the CRT?
Not recordable.
Look, listen, feel any signs of life?
Yes.
Okay. What about the peripheral pulse?
Weak.
What about the heart rate and monitor? Okay, I can see it's 77. Please, nurse, this patient looks in shock and hypovolemic shock. It could be hypovolemic shock. Please insert to IV cannula. Take blood for hematology, VBG, chemistry, blood culture, and toxicology, and give the baby 10 ml per kg normal saline.
I cannot find the IV access, doctor.
No worries, sister. No worries, nurse. We can go to intraosseous. We will go to the intertibial tuberosity 2 centimeter anteromedial. Okay, and we'll insert the intraosseous. Please, is there any bone marrow seen? Okay, we'll connect to IV line and give the patient and take blood, as I told you before, and give the patient normal saline 10 ml per kg. We'll go to check the disability. What is the ABO score?
Seizing.
Okay. Any signs of lateralization?
Yes, seizing.
Okay. What is blood sugar?
You ask about about pupils.
Pupils, yes.
The pupils unequal, dilated on the right side.
Okay. What is the blood sugar?
Blood sugar 15.
Okay, the baby has seizing and signs of lateralization, and he has pupil. It could be head. It could be intracranial pressure, increased intracranial pressure. Please call pediatric resuscitation team and neurosurgery, and we will give now the first dose. 5 minutes past. We'll give the first dose of lorazepam, 0.1 milligram per kg. Okay, and we will go to assess the exposure. Please expose the
So,
body. Any,
what is the problem, doctor, in disability?
it could be head injury because he has
The patient has no trauma.
it could be meningococcal septicemia also.
The patient has no temperature.
It could be sepsis also.
He has no temperature.
It could be epilepsy also, epileptic.
Yes, why the patient has resident intracranial pressure?
The
Okay,
most
continue.
Okay. Any exposure, any other abnormality in the exposure?
No,
What is the temperature?
normal.
Okay, I need to hand over the patient to pediatric resuscitation team
For what?
for admission and for more management and assessment. I need to reassess the patient again. What is the upper score?
The baby is unresponsive.
Look, listen, feel any signs of life?
Yes, but seizing.
Okay. What is the airway patent?
Patent with non-repressive mask and
Okay. SpO2,
normal.
blood pressure,
It's okay, improving.
upper score, still seizing.
Yes,
Okay, we'll give the second dose of lorazepam now, 0.1 milligram per kg IV, if we can find the IV access now. So I need to hand over the patient to the pediatric resuscitation team. Meanwhile, I will assess the airway again. What is the upper score now?
seizing.
Okay, airway still patent.
Yes,
Okay, SpO2,
normal.
blood pressure,
Normal.
AVO score
Seizing.
is still seizing. Okay, still seizing the baby.
Yes,
Okay, we'll give the third now. We will start infusion, levetiracetam, 30 milligram IV over 5 minutes. Okay, is the pediatric resuscitation team here? Okay, I will reassess the patient again. What is the upper score now?
seizing.
SpO2, is the airway still patent?
Yes,
Okay, what is the SpO2?
normal.
Blood pressure?
Normal.
Okay, what is the upper score? Still seizing? Still the baby seizing?
Yes,
Okay, we can go to rapid sequence induction. We will give the patient propofol, 1.5 milligram IV, and we will intubate the patient. After intubation, we'll attach to back valve mask, and we will recheck the we'll give the one ventilation every 3 seconds, and we will recheck for success bilateral chest auscultation,
yes,
equal. Okay, bilateral equal raise
yes,
chest. Okay, SpO2.
normal.
Okay, and the ETCO2.
Normal. Okay, thank you,
Okay,
doctor. Thank you.
thank you.
Okay, well done, Ali. Your time finished 30 seconds ago, but I give you a chance. Okay, so this patient is seizing in airway. You can just clear the airway through the nasopharyngeal airway. You can try mouse also. You assumed the mouse is clenching, but you should.
Okay.
You should say clear the airway, oropharyngeal, nasopharyngeal, and non-rebreather mask. But when the actor, whatever nurse or junior doctor, say I cannot open the mouse, you can say no worries, ignore the mouse, and you can clear the airway through the nose. Easy?
Yes, sir.
So don't assume. You ignored the mouse and you assumed it's already
Clenching.
clenching. Okay. Then breathing done, circulation done. You give the patient IV failed, then IO access. Once you insert IO access in the exam, you will find the opening here or opening here. Just follow the opening, okay?
Okay.
Maybe here, maybe in the femur, maybe in the proximal tibia, maybe in the distal tibia. So just to mention the location of the opening, okay? Then you can say IO axis inserted in the blah 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 blah. Label the sample by IO axis, okay?
Yes, sir.
So you will take for hematology, biochemical culture, toxicology screen, and so on. You finished already the disability. You started the first dose of um, lorazepam. Did you mention 5 minutes passed? It could be status epilepticus.
I think so, sir. I think so. I'm not sure.
I'm not sure. All. Okay. So you should say 5 minutes passed. It could be status epilepticus. Start the first dose. So don't start the dose until you verbalize the finding, until you verbalize the diagnosis, right?
Yes, sir.
Otherwise, why you give the first dose? Okay.
Yes, sir.
Okay. So this diagnosis status epilepticus. If no status epilepticus, so for example, if the patient is seizing for 3 minutes, is it logic to give first dose? No.
Yes.
Okay. So you are doing well, but I'm trying to optimize your approach. So first dose given. And the next disability, did you mention 5 minutes past? No. And the next dose or medication, did you mention 5 minutes past? No. Okay.
Yes, sir.
So you missed these points. Otherwise, maybe you are giving every minute. No. Clear?
Yes, clear, sir.
Okay. This affects the safety. If you are giving without reasonable cause, it's not logic. Okay.
Yes.
Okay.
Sir, for your question about the head about the pupils and equal,
Yes.
what
So,
is the
yes. What is the diagnosis, guys?
Decay.
DKA, yes.
Decreased
And what is the
intracranial.
complication?
cerebral
High blood
edema?
sugar, high
Cerebral
blood
edema.
sugar can cause
Cerebral
cerebral edema.
edema. Cerebral edema. So, if you find the blood sugar is 15 millimole, it means hyperglycemia, so DKA. Okay. And if the pupil unequal, so cerebral edema. That's why the patient has seizures, right?
Yes, sir. I'm not sure if I heard you that you are 15. I didn't. I mean I didn't completely hear your blood sugar, blood glucose.
Because you are not expecting.
Yes, you are right, sir.
If you are expecting, if the examiner mention 1 liter, you will catch.
Yes, sir. You are right.
If you are preparing well, once the examiner will mention 1 liter, you will catch because you are expecting the causes of seizures here. Did they mention in the scenario head injury?
No.
No. Okay.
Yes.
Did they mention anything relevant to blood sugar? No. Please mute your mic, guys, if you are on duty. So regarding the point of blood sugar, head injury, they can write in the scenario, or the mother can tell you, right?
Yes, sir.
The mother did not mention. So they said here history taking, right?
Yes.
So you have resuscitation and history. It means you should take history from the mother. History here, it means
What happened? What happened with the
hand
child?
over from ambulance crew or mother.
Yes.
Number 2, okay?
Yes.
Do you need to take history complete history? No. 2 questions, 3 questions, 4 questions maximum. Easy?
Yes.
So if you ask her how can I help you or can you tell me more what happened? She will give you all information. Done. Okay. So
Yes, sir.
one open question, more than enough to take history. Okay. So if you want to consider the causes, it could be head injury. If you want to say about head injury, you can mention all differential diagnosis. You can say like that. The patient has seizures. It could be head injury, but no history. It means you are mentioning that, but you are ruling that to the examiner. Easy.
Yes.
It could be sepsis, any blood results, any lactate. Maybe he will mention normal. Maybe he will mention not yet available. Okay. You can say it could be electrolyte imbalance, any blood results. It could be hypoglycemia or hyperglycemia. What about blood sugar? Like that. Okay.
Yes, sir.
So the patient, if hypoglycemia, it can cause like that. If hyperglycemia also can cause that, especially if raised intracranial pressure, whatever, because of cerebral edema. It could be infection, yes, as you mentioned, but you have to make it reasonable. So you can ask, it could be infection like meningitis or anything like that. So any blood results, what about blood gases, like that, okay?
Yes, sir. Okay.
Okay.
Thank you, sir.
I will give you 8 out of 10. Thank you.
Thank you.
Next one. Anyone did not practice today? Otherwise, we will go from the beginning. Anwar?
Yes, doc.
Okay. So this station methadone, what does it mean, methadone?
Opiate.
It means which system?
Disability D.
Okay, disability. Excellent. Okay. So you will find RR low, ANFPO score not alert. It could be V or P or U. The pupil pinpoint. Maybe the baby took medicines of the grandmother, right? So what is
Yes.
the first action? Bolus or infusion?
Bolus.
Bolus. So you will give naloxone. In adult, we say 400 microgram. In pediatric, we say 100
100 microgram.
microgram per kilogram. Maximum per dose 2 milligram. I wish it's clear.
Yes.
Okay, well done. Then you will finish all the system. Then I will reassess the patient. You are giving every
2 minutes.
2 minutes. If you want to every 1 minute, accept it. If you want every 3 minutes, accept it. Okay, but I prefer every 2 minutes. So once you plan to reassess the patient, you can say 2 minutes passed, I will reassess the baby. If you find no change in the points of triad, you can give another bolus, same dose. Third assessment, if no change, again third bolus. So at any time you find any change of any parameter of the 3 points, you will give infusion. Clear?
Yes.
How much infusion?
60% of the previous doses.
Excellent. 60% of previous doses means 60% of the rescue dose. Rescue dose, it means the total doses caused effect or made effect. Okay?
Yes.
Okay. You have 30 seconds and 6 minutes.
Good morning. I'm Dr. Anwar. I'm the ED registrar and the team leader today. Are you all APLS trained? I need 2 nurses, 1 for airway and 1 for circulation equipment, please. We are awaiting a patient who has drowsiness after overdose of methadone. Is the patient arrived?
Yes, doctor, this is my son. He took these medications for my mother. What is this, Dr. Methadone? What is this?
It's an opioid medication. It can cause drowsiness of the child. Don't worry, we will take care of the child. I will assign 1 nurse to keep you updated throughout the whole process. We will now begin assessment of our child. What time did he take this medication? Okay, we will start assessment of our child. What is the AVPO score?
Unresponsive.
Look, listen, feel any signs of life?
Yes.
Okay, is the airway patent?
No, the airway is not patent. The patient has a stridor and the secretions.
Okay, please clear the airway, suction the airway, OP, NPA, high flow oxygen, reposition the airway. Let's move on to breathing. Please connect all monitors, expose the chest. What is the RR?
RR is 4.
What is the saturation?
80.
Okay, what about trachea and neck veins?
Normal.
Inspection, palpation of the chest?
Poor respiratory effort, decrease the chest rise, decrease the expansion.
Okay. Okay, what about percussion?
Resonant.
Auscultation of lung and heart sounds?
Normal.
Okay, guys, we have a patient in a severe bradypnea with hypoxia. Please connect back valve mask and start giving rescue breaths. 1 breath every 3 seconds, please. Let's move on to circulation. What's the blood pressure of the patient?
Not recordable.
Look, listen, feel any signs of life?
Yes.
Okay, what about the pulse rate and rhythm?
Weak.
What about peripheral pulses? Okay, patient is in bradycardia. What about the peripheral pulses in CRT? Okay, we have a patient with bradycardia and hypertension. Please connect to large bore IV cannulas, start take samples for hematology, biochemistry, blood culture, blood gases, toxicology screen, and start IV fluids, 10 ml per kg. We have the typical triad of poor responsiveness, poor GCS. Can we see the pupils of the patient?
Pinpoint.
Okay, what about the blood glucose?
5.
Any signs of lateralization?
Normal.
Okay, so we have a patient with typical triad of low GCS, pinpoint pupils, and bradypnea. This could be opiate toxicity. Please collect the samples as I have advised and give the patient 100 microgram per kg of IV naloxone bolus. Can we expose the patient any abnormality? What's the temperature of the patient? Okay, 2 minutes have passed. I want to reassess my patient. Can we go back to AVPU? What is my baby alert? Is the child alert? Okay,
The
is the
baby
AV
is
patent?
still unresponsive.
Okay. Look, listen, feel any signs of life?
Yes.
Okay, let's go on to airway. Is the airway patent?
Patent.
Okay, what about breathing? Is the RR improved or is it still 4?
Same.
Saturation,
80.
blood pressure.
Same.
Okay, 2 minutes have passed and there is no response to the initial bolus. Please, nurse, administer another bolus of 100 microgram per kg, IV bolus, naloxone, please. And then we will reassess the patient. I think we should consider 4 H's and 4 T's. I think in this patient, the
Why 4 H 4
reversible
T?
cause is...
The patient is alive.
I'm sorry. Okay, we will give the second dose of naloxone, 100 microgram per kg, and then after 2 minutes have passed, we will reassess the patient. Is the patient alert now?
The patient is unresponsive.
Look, listen, feel any signs of life?
Yes.
Okay, is the airway still patent?
Yes.
Any improvement in RR?
Same.
Okay. What about blood pressure?
Patient unresponsive now.
Look, listen, feel any signs of life?
No signs of life.
Okay, nurse, this patient is in cardiac arrest. Please announce the pediatric cardiac arrest board and alert the intensivist and pediatric intensivist. And please give 5 inflation breaths and start high quality CPR. Compression to ventilation ratio 15:2. Let us consider 4 H's and 4 T's. I think in our patient, the most likely reversible cause is T, toxin. This is opiate toxicity. Please let us give another bolus of 100 microgram per kg naloxone IV bolus and continue high quality CPR. Can we check the rhythm on the monitor, please? Okay, this looks like PEA. This is a non-shockable rhythm. Please also administer IV 20 microgram per kg, 10 microgram per kg adrenaline IV bolus, please. Continue high quality CPR. 2 minutes have passed. Can we stop? Check the rhythm and pulse. Any signs of life?
Yes.
Okay, excellent, guys. We have achieved ROSC. Let's move on to post-cardiac arrest algorithm. And we will reassess the child now. Is the baby alert?
The baby is responding to verbal.
Okay, he's still unstable. Is the airway patent?
Yes.
What about breathing? Has it improved, the RR?
RR is 14 now.
Okay, excellent. What about the saturation?
Okay, thank you.
Okay, thank you.
Thank you. Your time finished 30 seconds ago. Okay. When the patient has cardiac arrest, did you give bolus of naloxone?
Yes, doc. I give the third dose.
Yes. When the patient has ROSC, did you give infusion?
Yeah, I was about to come to that talk in circulation. I
Okay.
was about to
Yes,
give
because
the infusion.
ROSC here, it means response, right?
Yes, correct.
Okay.
Yes.
You have to confirm that by AVBO score, no problem. I told
Oh,
you responding to V, right?
yes.
Okay, it means when you are calling him, he's opening his eyes. Okay.
Yes.
So RR, I told you 14. So you can say the patient has
Response.
a response, the AVBO score improved, the RR improved. If you want to continue disability, no problem. I mean, if you want to
Okay.
confirm the triad, but anyway, any partial response indication to give infusion. Easy?
Yes, no.
Okay. But I mean, if you want to start infusion after disability, even pinpoint pupil is still the same, no problem. Okay. I will give you 8
Okay.
out of 10. Thank you. Well done. Thank you.
Okay, doctor. Thank you.
Next one, Omar.
Yes, Dr. Hamid.
Yes. So this baby, this is the last station. Fell in a swimming pool. Okay.
Yes.
What does it mean, a swimming pool?
Hypothermia.
Okay. What does it mean, guys, the swimming pool?
Hypoxia.
Drowning.
Hypothermia or
Hypothermia.
Hypoxia, hypothermia.
Drowning, hypothermia. But I mean, what does it mean in Arabic?
In Arabic.
أيوه.
غرق. غرق.
مسبح. Okay.
أيوة مسبح. غرق في المسبح. أيوة.
Okay. Because some doctors they don't know the meaning of a swimming pool. Okay. Of course, the non-Arab doctors they are aware about the meaning. Okay. So if you find that in the exam, unfortunately, one doctor, no need to mention name, she asked about, I will consider for H40s, it could be toxin. Why toxin? A swimming pool. It means, think about what?
Hypothermia.
Hypothermia. Okay. They give her misconduct because she doesn't know the meaning of a swimming pool. Clear, guys?
Yes.
Anyway, she asked me, I told her, tell them I don't know the meaning of a swimming pool. That's why I considered for H40. You're right to consider for H40s. No one can give you misconduct. Even if you will think, because they think toxin irrelevant to swimming pool. Yes, even irrelevant. It's sorry, it's not your issue. I have to consider everything. Clear, guys, this one? Okay.
Yes.
So anyway, you can say I will consider for H40s. The most likely problem is hypoxemia. Hypothermia. Okay. Hypoxemia
Yes.
because the baby is drowning, and the hypothermia because the cold water. Okay. Okay. Um, Omar,
Yes.
I think we did this station in adult. It will be the same. So they
Yes.
can give you a patient alive in the beginning. Okay, so if the patient has bradycardia, what is the action?
Oxygenation, optimize oxygenation.
Oxygenation and passive active rewarming. I'm talking about a live patient. Okay,
Yes.
so oxygenation, you will do passive active rewarming. It
Yes.
means humidified warm oxygen. You will give IV fluid warm and dry the patient, cover with warm blanket. The air condition will be warm. Easy?
Yes.
Okay, well done. Okay, so what if they give you unresponsive in the beginning? I mean, look, listen, and feel no signs of life. So cardiac arrest. Take your time to verbalize everything. Okay,
Yes.
so you will expose the chest, connect all monitors to IV access, extract the blood for blah blah blah. Attach the monitor, non-shockable rhythm, BAA. Then I will consider for H40s. The patient fell in a swimming pool. It could be hypoxemia. It could be hypothermia. Check the temperature by low reading thermometer. It's a 26. Easy?
Yes.
like that. So you will say withhold cardiac drugs because the temperature is less than
30.
30. Excellent. Then start activate blah blah blah. Already you activated, you called, and start high quality already done. Then for 2 minutes, of course, high quality CPR. What else? Passive and active warming. Then verbalize them. Once you finish everything, you have nothing else to do. You have nothing else to verbalize. Then 2 minutes passed. I can see rhythm still the same. Any signs of life? No. Easy?
Yes.
And so on. You find the patient in the third cycle. The patient now has VF. Okay. So what you will do, continue high quality CPR. In the meantime, I will charge DC shock unsynchronized biphasic. How much?
4 joule per kg.
4 joule per kilogram. Excellent. Okay. Joules are ready. Then stop CPR. Give the shock. Resume high quality CPR for 2 minutes. Easy.
Yes.
Some people will say, I will give this shock immediate or I will continue CPR until I will recharge the joules. To be logic in real practice, the defibrillator not ready, right? You will
Yes.
stop CPR, interrupt CPR, for example, 20 seconds until you charge and give shock? No, not logic. The maximum interruption 5 to 10
Second.
seconds. Okay. And this interruption, not for shock, this interruption, for example, you are checking the rhythm, you are checking the pulse, you are checking, you are intubating the patient, you are doing focus, like that. Easy?
Yes.
Okay. So you will withhold the cardiac drugs if less than 30. Regarding shock, you can give this shock, no worries. You can give up to 3 this shock. If it's still less than 30, you can um, withhold
Hold.
cardiac drugs and withhold this shocks. If the temperature became more than 30, you can continue this shock and you can continue cardiac drugs, but with double interval. It means adrenaline every 4 minutes, it will be every 8 minutes.
8 minutes. Yes.
Amiodarone after the third shock and then the seventh, the first shock, it will be after the third and after the seventh. Okay? So it means every 4 minutes. You know,
Yes.
amiodarone should be every 2 minutes, right?
Yes.
Sorry, every 4 minutes, but you will double, it will be every 8 minutes. Right. Again,
Yes.
after third shock, after fifth shock, what does it mean?
4 minutes.
4 minutes, because one cycle, 2 minutes, right?
Yes.
So amiodarone every 4 minutes, it will be every 8 minutes, okay?
8 minutes. Yes.
Okay, well done. You have 30 seconds and 6 minutes. So every cycle, you will verbalize 2 minutes CPR, you will verbalize passive active warming, you will verbalize shock temperature, okay? 3 points
Okay.
every cycle.
If temperature become more than 30 and I already give 3 DC shock, I will count from the start. The fourth shock, it considered the first after 30 or the considered the fourth?
No, irrelevant to temperature, regardless of the temperature.
Okay.
Don't count DC shock in alive. You will count any DC shock in cardiac arrest. Clear?
Okay.
Regardless of temperature.
Okay.
Okay, you have 30 seconds and 6 minutes.
I can start?
Yes, please.
Okay. Good morning. I am Dr. Omar, the registrar. May I know your name and level, please? I need one nurse certified APLS for airway, another nurse for circulation.
Doctor, please, this my baby. I found him fell in swimming pool.
Okay, don't worry. Please be calm. I will assign one nurse for you. I will take care of the baby and you will restate him. What AVP score? Have we score? If the patient is conscious,
Unresponsive.
look, listen, and feel any sign of life.
Yes, the patient has signs of life.
Okay, patient has sign of life. Patient has sign of life. Okay, what about airway?
The airway is not bad in secretions, doctor.
Okay, please do suction, oropharyngeal, nasopharyngeal airway, and connect patient to high flow oxygen. What about saturation?
Not reading.
Okay, look, listen, and feel any sign of life.
No signs of life.
Okay, patient is already in cardiac arrest. Please activate pediatric resuscitation team, pediatric cardiac arrest team. Attach all the monitor, give 5 rescue breaths, and start high quality CPR with the compression ventilation ratio 15 to 2. Please connect all the monitor, and I will check the rhythm. Okay, patient have non-shockable rhythm, pulses, electrical activity. Please continue CPR for 2 minutes and give continue and CPR for 2 minutes. Insert IV access and take blood for hematology, biochemistry, blood gas, blood culture, toxicology screen. Please, I will consider for H and for T. The most likely problem here, the patient have fall in swimming pool, hypothermia or and hypoxemia. Please check temperature for the patient with low grade thermometer. How much temperature?
26.
Okay, patient who already has hypothermia will start passive and active rewarming through humidified warm oxygen, warm IV saline, IV fluid. We will dry the baby, cover him with warm blanket, and turn on the air conditioner warm. 2 minute bus. What's the risk? Okay, still pulseless electrical activity. Please resume high quality CPR
Why
for 2
you
minutes.
assumed no signs of life?
Yes. Sorry. Any sign of life?
No.
Okay, patient still in cardiac arrest, pulseless electrical activity. Will resume high quality CPR for 2 minutes. Resume passive and active rewarming. Will check temperature and withhold cardiac drug as
27.
temperature is less than 30. Okay. 2 minute bus. I will check any sign of life.
No.
No, I will check the monitor. Now the patient have shockable rhythm, ventricular fibrillation. Please prepare DC shock continuous CPR for 2 minutes. Charge the DC shock. Resume active and passive rewarming and check temperature. Please give DC shock and synchronize it 4 joule per kilogram. What about temperature? And withhold cardiac drugs.
28.
Okay, 2 minute bus. Any sign of life?
No.
Okay, rhythm still shockable rhythm. We'll give second shock and synchronize DC shock for joule per kg. We'll resume high quality CPR for 2 minutes. Resume passive and active rewarming and check temperature, please.
29.
How much temperature? 29. Withhold cardiac drugs. 2 minute bus. Any sign of life?
No.
No. Still rhythm, shockable rhythm, ventricular fibrillation. We'll give third shock, DC shock, and synchronize it for joule per kilogram. Then we'll resume high quality CPR for 2 minutes. Resume passive and active rewarming, and we'll check temperature. If less than 30, withhold cardiac drugs. How much temperature?
29.
29. Still less than 30, withhold cardiac drugs. 2 minute bus. I will check any sign of life.
No.
Please resume withhold the fourth DC shock, and we'll resume high quality CPR. Resume passive and active rewarming.
Temperature
And
now 33.
okay, now temperature is 33. This is good. We'll give the fourth shock. We'll give the fourth shock 4 joule per kg. In the meantime, we'll give amiodarone 5 milligram per kg. We'll give epinephrine 10 microgram per kg bolus, IV bolus. We'll continue passive and active rewarming, and we'll check temperature. Any sign of 2 minute bus, any sign of life?
Yes.
Yes, now, excellent, guys. Patient achieve ROSC now. I can see normal sinus rhythm ECG, and we'll assess the patient. Is the patient conscious?
The patient is crying now.
Okay. What about airway?
Normal.
Okay. What about saturation?
Normal.
Blood pressure?
Normal.
Trachea?
Normal.
Neck veins?
Normal.
Inspection, palpation, percussion of chest?
Okay, thank you. Your time done. Okay, excellent, Omar. So after ROSC, you finish. Did you assess the airway before cardiac arrest? Yes. Did you
Yes.
assess breathing before the cardiac arrest? Yes, right? But
Yes.
when you assessed breathing before cardiac arrest, I told you the saturation not reading. That's why you ask look, listen, and feel. And I mentioned the patient has no signs of life. So you did not assess the breathing, right?
Yes.
So after ROSC, you should assess complete breathing, right?
Okay.
So assess complete breathing, then complete circulation, then complete disability, and so on. Easy? I need
Yes.
to hand over this patient to.
Pediatric ICU team for admission and observation.
Yes, excellent. Okay. So this patient, if responding to B, you should intubate, okay? Any baby responding to B, what is the action?
Intubation.
Intubation. What does it mean responding to B?
Pain. Responding to pain.
Yes, it means he has no reflexes. Okay?
Yes. Yes.
So what else? Any baby or any adult tolerating oropharyngeal, what does it mean?
Responding to verbal.
Need
Gag reflex.
No, gag reflex.
Intubation.
Hmm.
Any patient tolerating oropharyngeal, intubate.
Need intubation.
In real practice or in the exam, once you put the oropharyngeal, the patient is silent, not moving the oropharyngeal. It means bad sign. You should intubate. Easy?
Yes.
If you put oropharyngeal and the patient is removing, this is good or bad?
Good.
Good.
You are putting oropharyngeal in the mouth and the patient is pushing by his tongue. This is good or bad?
Good.
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 So remove, right?
Yes.
You will remove and keep the nasopharyngeal airway and then high flow oxygen. Okay?
Yes.
Unfortunately, not non-knowledgeable doctors, they are forcing. He is pushing by his tongue. They are forcing. They are forcing. Why? Okay. So patient not tolerating oropharyngeal, remove and don't intubate. Patient is tolerating, he is silent, it means intubate. Okay. You did well, Omar. I will give you 9 out of 10. Well done. Um, I wish if you finish your task, you reach handover, so exposure was complete, okay, after ROSC. Well done.
Okay.
Anyway, I try to give you many cycles. In the exam, brief cycles, maybe 2 BA and 4 shockable. So non-shockable and shockable, okay? So
Yes.
I try to give you many cycles anyway. You did very well. Excellent, guys. Inshallah, the next decision will be on
Wednesday.
Wednesday, same time, 12 p.m. UK time in Ramadan. And it will be
APLS.
APLS. Okay, excellent. Okay, please prepare well. Listen to previous recordings and be ready for APLS. Thank you, guys. If anyone has any
Thank you.
question, put in the group, please.
Okay.
Thank you. Bye bye.
Thank you.
Thank you.